microbiology or microbiology related services in the hospital wherever you go. So this would be
I think Madam had a connection issue. She will join shortly. So, so make sure all of you all log in today by your merit number, if you all have a merit number. Foreign graduates by their name with initials. So yes. Madam, we'll start from the beginning.
didn't you hear anything what I said?
No.
Okay, right. So
We heard the introduction, that's all.
okay, right. Okay, right. So as I don't know, I'm really sorry for the
That's okay, madam.
that,
You can make it full screen, that's all.
okay, right. Okay. So the I don't think you have heard this part also.
No. Yes.
Okay, right. Okay. So regarding the content of my lecture, I would be giving a brief introduction related to the service microbiology services that we are providing in a hospital, and especially regarding the microbiology diagnostic services, regarding the referrals or antibiotic recommendations that we would be giving, and of course regarding the infection control practices. So the basic objectives that we need to give you all is to give an overview of the microbiology services, as I said, and to help you all in developing skills on managing infections, and to guide you all in rational prescribing, to give basic knowledge on infection prevention control practices, as well as to update your knowledge on collecting, storing and transporting microbiology samples in order to provide quality reports. So there are 5 resource persons for this workshop. The next lecture would be done by Dr. Shirani Chandrasiri. She is the consultant microbiologist attached to Columbus South Teaching Hospital. And the third lecture will be done by Dr. Dhammika Vidanagama. She is the consultant microbiologist attached to Lay Ridgeway Hospital, Borella. And fourth one would be done by Dr. Madhumani Abevadana, and she is the consultant microbiologist attached to National Hospital Kandy, and Dr. Geethika Patapandike, who is the consultant microbiologist and the current president of Sri Lanka College of Microbiologists, and she would be doing the last lecture to you all. So when we talk about microbiology, you all know that the microbiology is mostly the science that deal with several microbes, namely bacteria, viruses, fungi, parasites, all the things related to microbiology, the microbes will be dealt with this microbiology science. Even though our customers or the dealers are micro, services are not that micro, it's massive. Actually, microbiology team in a hospital deal with several things related to microbiology and related infections. And I would be talking to you about 2 main things, because it is relevant to you as pre-interns or intern medical officers to know what these services are. So the first thing would be diagnostic services, and the second one would be giving antibiotic recommendations to help you all with managing infections. And the third one would be infection prevention and control, which is very, very important, because we all know it is very difficult when you have a disease. Managing a disease would be really difficult, but if you have a means of prevention, that is what we have to always encourage and promote. So infection prevention and control is a major part of managing hospital related infections. So as I said, there are two main services. So I thought I should give an introduction regarding the hierarchy, or the people who are involved in these 2 services, because you as intern house officers need to collaborate with these staff members so that to get the maximum help from them in managing infections. So there are medical officers in microbiology. In each hospital, actually, there would be a microbiology lab. So microbiology lab is there, and depending on their capacity, they do several diagnostic services. There is a medical officer in microbiology in most of the labs. They are the people, they are the doctors who collaborate with the ward staff and the clinicians, especially with you all in the clinical liaisons. They help you in sending samples, giving instructions on the samples that to be taken to diagnose certain illnesses, diagnose certain infections, and they also help in interpreting these reports also, and time to time giving instructions on what antibiotic you should use. So they are really important. So try to collaborate with them, try to get the help from them, ask anything that you want related to microbiology diagnostic services, and they will help you. And in the microbiology lab, there are one or more medical laboratory technologists who do the processing of samples and do the relevant work related to the samples that you would be sending. So it is important to collaborate with them and talk, to have a good rapport with them, so that to get the things done in a proper manner. And there are minor staff or lab assistants also working under them, doing a lot of work, even though you only get a piece of paper with a isolation written on it, and with a maybe with a antibiotic sensitivity report, but to produce that report, there are a lot of people work tiringly behind the scene to give a quality report to you all. And the other aspect, or the other service which come under a consultant microbiology, would be infection prevention and control. And sometimes there are medical officers who are involved in infection control, but not all the hospitals have a MO in infection control. So you only have infection control nurses, and there would be one or more infection control nurses. The wards or units have one called liaison nurses. These liaison nurses are responsible for the supervision of infection control activities done in their respective unit, because most of the time, even though we do daily ward rounds, the nurses do daily ward rounds related to infection control, but most of the time the liaison nurses would be the one to detect any breaching of these practices, or whether they need more vigilance over certain things. They are the people who have the first-hand experience. So they are the people who liaise with the infection control nurses to establish these infection prevention and control practices. So I would be talking about the microbiology diagnostic services, and the main role of the microbiology lab would be to give diagnosis of infections in a patient in order to help with the management of the infection. As I said, when you send a sample, we will be accepting it with the help of you all, because you need to send a proper request form. I think Dr. Madhumani would be talking to you regarding collection and transport. So request form is a very important part of the pre-analytical part of the microbiology testing. So you need to send a proper history. You need to send proper samples which are collected properly. When there is a good sample, we would be able to provide with a quality report. And the other main role of the microbiology lab would be to support infection prevention control, especially when there is a outbreak or when there is a transmission of hospital-acquired infection. The microbiology lab can help the infection control team in searching for the source of this infection and the route of transmission by doing several cultures. So you all know the diagnostic methods of infection from your medical student days. There are classical methods and there are molecular methods. Most of the routine microbiology laboratories do not have molecular methods, except thanks to COVID-19 pandemic, most of the hospitals in Sri Lanka got some way of molecular method or quick molecular method. But however, for other bacterial and viral infections, we only have classical methods of diagnosis. So there are several stains that are being done. Those are direct smears. So especially Gram stain as well as acid fast stain. And those are the most famous stains that would be doing in a microbiology lab. But there are certain other staining which we use for time to time to diagnose infections. And cultures, of course, most of the microbiology lab would be doing bacterial cultures, not viral cultures. And there are several samples which are accepted for these bacterial cultures. When you send a bacterial culture, if there is a pathogen, if we think that there is the isolation which we would be getting can cause infections, we would be doing or we would be issuing a antibiotic sensitivity report together with this culture. So with this antibiotic sensitivity culture report, you would be able to give more targeted antibiotic therapy to your patient, because it is very important in preventing the antibiotic resistance. I think this topic will be discussed further in the next lecture. And we also do several antigen detection as well as antibody antigen detection as serology testing. These may not be really readily available in almost all the microbiology laboratories, but in major microbiology laboratories as well as in reference laboratories, these would be available for you all. Molecular methods, of course, there are PCR methods, RT-PCR methods, hybridization methods. All those are mainly done in established molecular laboratories. So there are usual samples which are accepted to a microbiology culture, which are blood, urine, pus or tissue or biopsy cultures, various swabs, ENT, ear, wounds, throat, and of course screening swabs like MRSA. Respiratory secretions are accepted for cultures like sputum, ET secretions, and tracheal secretions, as well as BAL, bronchoalveolar lavages, stool, CSF or any other sterile fluid or aspirations like peritoneal fluid, knee joint aspirations, pleural fluid, all those will be cultured depending on the facilities available. And samples related to infection outbreaks, as I said, if there is a relevant samples to be taken, infection control nurses would be taking samples and it will be processed in our microbiology laboratories. These are available in every microbiology culture if the facilities are there to do this. Sometimes, depending on how large your hospital lab is, you might have to send these sample to outside for another or reference laboratory, depending on the facilities. So as I said, the rapport between the microbiology team and the clinical team is really important because it is a two-way process. If you don't give the details that we want to get an idea about the microbiology sample, we will not be able, because what you have to understand is the main important thing in microbiology is in cultures, we don't usually, if we have the facility to grow bacteria. So anything that grow in a culture plate doesn't mean that it is the pathogen. That is the most difficult part of interpreting the microbiology reports. So a proper history and the details will be very, very helpful in interpreting whether it is a culprit. For an example, you all know that blood culture may have a coagulase negative streptococci, and not always this the coagulase negative streptococci would be a pathogen. In certain instances only, it will be a pathogen, so it will be recognized as a pathogen only in certain situations, especially when the patient is having a prosthetic device, or when the patient is having a central line. At that time, we have to give a antibiotic sensitivity report in order to manage this type of patients. But in the other instances, it is a colonizer in our normal skin flora, and most of the time when we have a blood culture, if you don't give adequate history regarding whether the patient is having a prosthetic device, or whether the patient is having a central line or not, or if the patient's age is not mentioned, we would be considering this as a colonizing flora, and we will not be issuing a ABST report. So that is why I said it is very important to give us the certain points in your history. So when you give this is actually a chain reaction, because we are collaborating with you all regarding specimen collections and specimen transport. If you do not do a good transport, or if the conditions are not really favorable for the specimen during the transport, the specimen will be contaminated, and that specimen will not be very useful for us. So depending on the quality of the specimen, we will be processing our samples, that is the primary workout, and we will be issuing a culture. We will be giving an identification for the pathogen, and the sensitivity will be issued as a written report. And depending on this, you can start your treatment for this patient, or maybe change your treatment options according to the antibiotic sensitivity report. So for all these, you need to have a very good constant information flow. That is why you, as you are the people, intern medical officers are the first people to encounter patients, and they are the people, they are the doctors who spend more time with the patient than any other medical officer. Maybe SHOs are coming later, but you are the one who sees the patient first. So most of the information will be taken from you all, and most of the things will be discuss with you all, and most of the instructions will be given to you all. So that is why it is very important to have a very good rapport with the consultant microbiologist and the team. So the next service that we would be giving you all would be the antibiotic prescribing, and most of the time the microbiology team will be given referrals to certain patients, especially critical care patients, because critical in every hospital it is one of the main daily routine of a microbiologist to do ICU rounds. In the ICU, actually all the antibiotics will be decided and will be recommended by the consultant microbiologist when there is one available in the hospital. Because critically ill patients who are in the hospital are more prone to hospital-acquired infections, and preventing them from having HAIs are important, as well as if they are in early stage of hospital-acquired infection, it is very much important to treat them early, because HAIs carry very high morbidity and mortality. So regarding these referrals, there would be daily ward rounds, and microbiology doctors together with the consultant microbiologists would be doing daily ward rounds. So please try to give cooperation to them, try to be there when they are around, and get the advices that you need regarding the antibiotics. It is very important to daily revise, or maybe frequently revise, the antibiotic chart and decide upon the dosing, and decide upon the frequency, and whether the patient might be needing change of antibiotics. So all those will be sorted out by the microbiology round. So any advices which has to be taken regarding preventing the infection or preventing the infection spreading to another person also will be sometimes handled during these ward rounds. And also sometimes some patients continue to have fever even in spite of having several antibiotics. So sometimes you need to have further testing also, maybe related to fungi. So you need to do mycology cultures, and most of the fungal cultures or mycology cultures will be done at MRI in the Department of Mycology. And you need to send samples there. So whenever you need to send samples, you need to collaborate with the your microbiology team, as well as with the team in the MRI in order to get the things done. TB, the cultures will be done at Palliserra, and viruses, there are several places which provide the diagnostic services related to virology. MRI is the reference laboratory, and there are virology department in Kandy, Anuradhapura and Karapitiya teaching hospitals. Regarding the antibiotic prescribing, if you have any doubts, there is empirical and prophylactic use of antibiotic national guidelines published in 2016, and it is actually under revision these days. This was published by the Sri Lanka College of Microbiologists in collaboration with the Ministry of Health. So this book should be available in your units. If you have a free time, go through it and get familiarized with the antibiotic recommendations. And the last service would be infection prevention and control services in the hospital. So when you, it's like infection prevention control is a series of procedures and guidelines to prevent and control hospital-acquired infection, or HAI, as we say it in a short form. And these infection prevention control practices should be applied in all settings where healthcare is provided. It doesn't matter whether it is a hospital or maybe a GP practice or maybe a nursing care home, MOH, all in all the places. If you provide a healthcare facility, that means you have to abide by these guidelines of infection prevention and control. So these usually in our setting, actually in developing countries, these practices are always below the required standards because of the lack of resources, maybe because of the poorly designs, because most of our hospitals are not designed thinking about the infection prevention and control. Some wards, even though they are very heavy wards, there are no places to there are no wash basins had been established to do the hand hygiene or hand washing. So, and sometimes there are very basic errors in designs of operation theaters and other relevant places where infection prevention and control is very much important. So that is another reason for these practices are below the required standards. And overcrowding, of course, is a major problem in developing countries. Lack of basic facilities. Sometimes, even though all the things are there are no soap available for hand washing practices, and maybe alcohol hand rub is not available. Maybe hand towels are not available. Those are the things that we encounter all the time in our hospitals. Even though we talk about infection control practices from the morning to until night, lack of basic facilities due to various reasons, actually, even though could be due to money, lack of money, or maybe lack of financial help, maybe due to the attitudes of the board in charge. Maybe he or she might not be really enthusiastic about providing these things. Those are the things that we encounter day to day working life, and also the understaffing. So this is the Hospital Infection Prevention Control Manual, which was published in 2021. This gives a very comprehensive details regarding infection prevention and control, basic precautions as well as specific precautions, and infection prevention and control practices related to each unit of the hospital. So it is a very, very, very important manual. And since last year, we have been issuing at least a copy to the unit, especially in bigger hospitals, but not for the smaller ones. But I think most of you would be able to get hold of this manual and see whether there are anything related to you. As I said, this is a multidisciplinary thing. Infection prevention cannot be done by the infection control team only, or maybe the infection control committee only. This is a multidisciplinary thing. Everybody have to come together, and it should be followed by all the healthcare workers in patients at all the times. So I would be giving a basic idea regarding the organization of the infection prevention and control in the hospital. So it is very important in successful implementation of the IPC program in a healthcare setting. And this is a three-tiered organization. First one would be Infection Prevention and Control Committee, and the next one would be under the committee there would be a team, Infection Prevention Control team, and the last one would be Infection Prevention Control practitioners. That includes you all in the wards and all the healthcare workers in the hospital. So infection control committee, prevention committee has the director of the hospital in the committee, and consultant microbiologist is there, MO, infection prevention and control, infection control nursing officer, AO, accountant, matron, PHI, overseer, and all the other categories which are related to infection control. At least one representation should be there, and these infection prevention control committee would be meeting regularly to discuss any matters, acute matters, as well as long-term implementation things, if they need to decide upon those long-term implication policies related to infection prevention control. This is the committee that the coordinating with all the other people to take implementing role. So infection prevention and control team consists of the consultant microbiologist, MO, infection prevention and control if there is one available, and of course the ICNO. So duties of the IPC committee, as I said, there are two major responsibilities: setting up the infection prevention and control in the hospital as a long-term strategy, and should be taking timely and effective actions on acute problems like outbreaks. If there is outbreak, you need to take an action very quickly to prevent that, because most of the time with the outbreaks, you might have to sometimes close the wards, maybe sometimes close the ICU or the PBU. So it would be a very difficult situation to handle. So we need to, because infection prevention and control, even though we have the attitude, we have the basic knowledge on these things, we need to have the financial support as well as the administrative support. That is why there is a committee involved in this and take decisions regarding problems. And the next responsibility of the IPC committee would be ensuring the required infrastructure, funding, and the personnel available, because even though all the things are available, if there are no staff to carry out the infection prevention control activities, there is no point. Sometimes infection prevention control nursing officers are not available. So they are the people who are specially trained for this. So they are the people who can help others in establishing the policies and guidelines. So if there is no personnel around, it would be really difficult. So IPC committee makes sure that the all the required things are available to practice infection prevention. So the team actually, you will see when you start working in the hospital, there would be regular visits from the infection control team, especially infection ICNOs, and sometimes the consultant or doctors would be doing ward rounds to liaise with the ward staff, or to see whether there are any problems related to the infection prevention, or maybe if to see whether you are practicing them properly, we are coming to the wards, and we do a lot of surveillance as well as audits. For an example, we do hand hygiene audits, compliance, to see the compliance of healthcare workers, because it is very important, and hand hygiene compliance is one of the quality indicators of a hospital also. So every 3 months there would be a meeting in the Quality and Safety Department of the Ministry of Health to see and compare the hand hygiene rates of each hospital and to see whether there are any problems related to this. And of course, there are other audits like surgical site infections and sometimes bacteremia, MRSA rates. All those will be audited. All those will be surveyed under the surveillance. And there, if especially resistant organisms surveillance are there in certain hospitals, and antibiotic consumption surveillance are going on. Waste audits will be conducted by the infection control team. There are lots of things, even though you don't see much of the things in the out, there are a lot of audits and surveillance will be going on in your hospitals, and these will be conveyed to you time to time in when you work in the hospital. And the team is the executive arm of the infection prevention committee. When there are decisions taken at the committee level, infection prevention team would be the one to carry things out in the hospital. And of course, there are planning and training workshops will be conducted by this team. There are individual trainings, small training sessions, small training activities conducted in a ward setting, and sometimes as an induction program, there will be a lot of programs related to infection control. And you need to know that we are very careful regarding the sharp injuries or the needle stick injuries, and there are certain activities related to this will be conducted by the IPC team. They would be keeping registers of needle stick injuries, and they would be helping you all to take the post exposure prophylaxis and to direct you regarding these sharp injuries. And they also get involved in outbreaks also. So all this will be done by the infection prevention team. So I would like to thank the Sri Lanka College of Microbiologists and the Ministry of Health for giving me the opportunity to talk to you all. I hope, I know it's a very brief introduction. You will be encountering a lot of problems when you start working, but I think this would be a kind of good start. But if there are any questions, I can help you all and sorting this out. And there would be 4 more lectures also, so you can ask any questions from them also. Are there any questions? I think there will not be any questions from you all, because this is a very brief summary of what we are doing. And so if there are no questions, can I take a leave? Is that okay?
Yes, madam. Thank you very much for the detailed lecture. That was Dr. Kishani Dinapala from Teaching Hospital, Kuliapitiya. Thank you, madam. So if you all have some questions, you can still type in. So next lecture is by Dr. Chandrasiri.
There is one. There is one.
Okay,
madam, are there any instances? Are there any instances where a HO can go into disciplinary action due to microbiology staff? That's a very good question, actually. in fact, I don't know any type of nowadays actually any error from your part would be could be investigated. That is the especially with the social media and the involvement of the public. I don't know the all the things. Leading into a very different scenario than what we used to have. It's like you can, because any any intentional thing would be a penalized thing, but don't worry. We are always there to, I don't know, because may none the instance like that never happened up to now. All the microbiologists which I know of are very friendly and very helpful, that I can guarantee you. So don't worry, if there is a problem you can always come and talk to us, and we will be there to guide you all. And the next one is, dear madam, what is the pathway to be a microbiologist? Okay, so the easiest way is to finish the internship as the after the 1 year. I think you might need to have a 1 year of post-intern period, and there is a selection exam to select you all. If you get selected to this diploma, you will be you need to finish your diploma in microbiology, and that would be the entitlement for you to get into the MD pathway. And after MD exam, after 1 year of local training as SR and 1 year of foreign SR period, you would be able to get the board certification. But I am not the person to give a very clear description of this. Next speaker would be the chairman of our board of study, Dr. Shirani Chandrasiri. You can ask from her also. She would be able to give you a good guidance. Thank you all. Thank you, and all the best for your career. Thank you.
Right. Thank you, madam. Actually, there is thing called clinical audit. So a lot of cases or clinical management of patients will be discussed in future. I think the Director General of Health Services is the circular will be issued soon. So all the cases, deaths will be discussed in a clinical audit forum. So find mistakes. Okay, so next up is gravity of problem of microbiological resistance and rationale of prescribing. So is by Dr. Shriyani Chandrasiri, consultant microbiologist. I think madam is online. Madam, are you there? So I'm just looking at the participants. So not all are there. 121, 127. A lot of people are missing. So if they have not joined, ask them to join. Okay.
Good morning.
Yes, madam. Madam, we have. You can
Can
start,
you hear
madam.
me?
I've given introduction.
Okay. Thank you very much. I'm sorry about the delay in
It's okay.
setting up this presentation. Today, we are here to discuss the gravity of the problem of antimicrobial resistance and rational prescribing. As interns and thereafter as medical officers, you will be the prescribers in this country. So I want you to take a few messages with you today. So I have a question for you all. Who got the Nobel Prize for penicillin? Penicillin is considered the first antimicrobial. Is it possible for you to unmute and answer? Okay, there's something coming in the chat. Alexander Fleming. Answer is correct, 1/3. Fleming, Florey, and Che. 3 people got Nobel Prize for penicillin. Alexander Fleming was the first one to describe penicillin. However, to commercially prepare penicillin for Second World War was a real challenge. In the early days, patients' urine was collected to take the penicillin back. You know, most of the penicillin is excreted as unchanged penicilloic acid. That problem was solved by these 2 people who are not doctors but pharmacologists who went to USA during war and with 5 pharmaceutical companies able to produce penicillin. However, even with that, penicillin production was a problem. So there was a scarcity of this valuable antibiotic because that was the only antibiotic available. Second World War was sagging and supply was limited. This is a note taken from development of penicillin. So according to that, Dr. Chester Kiefer of Boston, who was the chairman of the National Research Council's unenviable task of rationing the supplies of the drug for civilian use. So according to this newspaper account, many laymen, husbands, wives, parents, brothers, sisters, friends begged Dr. Kiefer for penicillin. In every case, the petitioner is told to arrange that a full dossier on the patient's condition be sent by the doctor in charge. When this is received, the decision is made on a medical, not an emotional basis. So that was how penicillin was prescribed in the beginning. But do we do that now, even for most powerful antibiotics like carbapenems? We have never done that in this country. So this is the result of that. This is a single center study done at Sri Jayawardenepura General Hospital. According to this, percentage of E. coli and Klebsiella pneumonia isolates, resistance or cefotaxime, that's a third generation cephalosporin, meropenem, a carbapenem, and ciprofloxacin, a quinolone were this. Compared to Klebsiella pneumoniae, E. coli, carbapenem resistance was 7.5. But in Klebsiella pneumoniae, other two more than 50%, and for meropenem, it was 40%. In the same study, resistance of Acinetobacter species to meropenem and ciprofloxacin was, because cefotaxime is not active against Acinetobacter, these two are the given percentages, 85.5 for meropenem and 74% for ciprofloxacin. In a multi-center study of gram-negative bloodstream infections performed in 2013, this was 40% for meropenem. And ciprofloxacin resistance Salmonella typhi was 50%. We have done this multi-center study in 2009, and we did not have from blood culture isolate any meropenem resistance. So you can imagine what has happened over the years. My favorite slide. Penicillin was discovered before 1940. So this dark ages means before the discovery of antibiotics. You can see we have certain eras for antibiotic, and this is the antibiotic resistance. Even in his acceptance speech of Nobel Prize, Fleming describes the resistance, right? So you can see now we have many types of resistance, and we as discoverers, we are not describing any new antibiotics. Actually, during this period, only 2 antibiotics came. After 2000, we don't have that many important. What we are getting is now actually modifications of former antimicrobials. So we have golden era where we got many antibiotics. Then this we were discovering it from the natural environment. Then we were going for the pharmacological approach, then biochemical approach. Then we were looking at the target sites of the pathogens. Then we were describing the whole genome of the pathogens and trying to hit the pathogens through that. But with all that, we don't have many antibiotics now. So again, we have come to Semmelweis era. Semmelweis is the father of infection control, hand hygiene. So now again, our main approach has come back to infection control. This is a slide I have taken from a journal. Can you see changing life expectancy throughout the history? So first description is King of Judea, then Greek philosophers, Then Roman philosophers, they must have gone to Bacchus. So their life expectancy has come down a bit. But Christian church fathers, again Romans, their life expectancy is better. Italian philosophers, they have achieved 68.9, and Royal College of Physicians 67 in 1500. And from 20th century, you are seeing 15-year, at the age of 15-year, life expectancy has come to, by 1981, 72, and this 21st century, this has gone up to 83 in UK. What do you think about this slide? I am putting this slide for most of you to learn something. Look at data critically. This life expectancy is totally describing male life expectancy. Average life expectancy of a Roman female was 23 years. Giving birth to a child was life and death in that era. And this was a sample size of less than 100. And these people were privileged class in the society. Right? We are talking about them, but others, their life expectancy was much, much lower. So antimicrobials made that difference. Now, even an average person can expect, and what is Sri Lanka's life expectancy? There was an article saying German female and Sri Lankan female have the same life expectancy at birth. 83 something. All this was brought about by antimicrobials. So antimicrobial resistance will reverse all our gains. Survival of premature babies, transplant recipients, valve replacement, hip replacement, all these depend on antimicrobials. All these will reverse with the antimicrobial resistance. So it's a global health and development threat. It requires urgent multi-sectoral action to prevent or to minimize progression. I mean, already we have a big damage. According to WHO, it is one of the top 10 global public health threats facing humanity. It's a drain to the economy because severe prolonged illness results in longer hospital stays and need more expensive medicine. Just with penicillin, we were able to treat Staph aureus, but when we switched to penicillin-stable penicillins like flucloxacillin, cost went up. When we switched to vancomycin because of MRSA, cost went like 6 times higher. Those days, I don't know how much now, much more. So any use of antimicrobials, however appropriate and conservative, contributes to the development of resistance. But widespread, unnecessary and excessive use makes it worse. Overuse and misuse of antimicrobials facilitate over-the-counter availability without prescription. All this is causing bad prescription habits, and these incidents vary between countries. And this issue is made worse by substandard drugs. Misuse and overuse are the main drivers of resistance. Failure of adhering to good infection prevention control result in spread of these resistant microbes. Imagine a patient with multi-resistant Klebsiella pneumonia urinary tract infection in your ward with a catheter, and your minor staff person coming wearing the same pair of gloves, emptying all the urine bags, wearing the same pair of gloves. He will be giving it to all the patients with urinary catheters. Antimicrobial prescription is not limited to humans. So, you know, it is used as growth promoters and treatment agents in animal husbandry and even in agriculture. So we need one health approach to address this. WHO has realized this and they are promoting this one health approach. And we need antimicrobial stewardship in humans to limit antimicrobial use. There are various studies done on one. Famous one is RAND study, capital RAND. And this is taken from another, giving European and American resistant levels and predicted number of deaths due to this resistance in 2050. By 2050, Italy will have like 18 people of 100,000 persons dying due to AMR. This is much less in Iceland, where resistance is much lower. And you can see UK and Germany, where prescription habits are strongly controlled. They can expect lesser number of deaths. But imagine in Sri Lanka, it will be more than this. But at the moment, we are sharing the same life expectancy with Germany, but not in 2050. So this cartoon describes our fate. The antibiotics aren't working, so I uploaded your case history. All we can do now is hope it goes viral. In Sri Lanka, antibiotics are scheduled to be drugs. So only by registered medical practitioner. In other countries, there are nurse practitioners, but in Sri Lanka, it's only registered medical practitioner. That means MBBS or RMP. Not by Ayurvedic doctors. This is according to the Cosmetic Devices and Drug Act of Sri Lanka. So, how to rationalize prescription? Indications for antibiotics could be therapeutic. That is what you will do when you go to the hospital as intern house officers, giving antibiotics for proven or suspected infection. When you are giving it for suspected infection, it's empiric therapy. For proven infections, it's specific therapy. Then you have instances giving prophylactic antibiotic. For example, most surgical patients coming for elective surgeries will get prophylactic antibiotics for that surgery. Then there are not very 100% sure patients where indication is doubtful, but you will start antibiotics, but you will investigate these patients. They might turn out to be due to some other non-infective reasons, because fever is not a symptom of antimicrobial deficiency or not always due to infections. Even myocardial infarction or CVA can give fever. Even some malignancies can present with fever. This is from Center for Disease Control, America. Antibiotics are misused in a variety of ways. Given when they are not needed, Continued when they are no longer necessary, given at the wrong dose. Broad spectrum agents are used to treat very susceptible bacteria. The wrong antibiotic is given to treat an infection. So these are main misused ways. Give me some example given when they are not needed. You remember COVID patients, if you have gone through their prescriptions by GPs, you will see levofloxacin, azithromycin. I mean, it's a viral infection. Most of these patients who died in ICUs, not died because of COVID, but died because of resistant antimicrobials and started third generation cephalosporins. Triple therapy. Continued when they are no longer necessary. Surgical prophylaxis, either single dose, 24 hours, maximum 48 hours. But continuing for 5 days or till discharge is unnecessary exposure. Given at the wrong dose. I mean, this is done in many instances. Please refer some guide without giving wrong dosage. Broad spectrum antibiotics are used to treat very susceptible bacteria. For example, hemolytic streptococci, you don't need meropenem, but if you go to wards, you will see some senior registrars starting meropenem for cellulitis. The wrong antibiotic is given to treat an infection. One example is a patient we have seen with urinary tract infection. He was given linezolid, a reserved antibiotic without any gram-negative activity. Patient presented to the hospital because of the side effects. And most of the urinary tract infections are gram-negative. So start with the narrowest spectrum antibiotic for your clinical indication. I mean, small print, if this is not life-threatening, you will come to sepsis with Dr. Dhammika Vidhanagam and you will see that this is not the way we manage sepsis, severe sepsis, but in your usual day-to-day patients, remember this. Have a working diagnosis, then start with the narrowest spectrum antibiotic. Then use the laboratory investigations rationally. So then you can separate viral from bacterial infections. Most viral infections are self-limiting. CRP, full blood count, and blood picture might give clues. I mean, you don't need blood picture most of the time. CRP and full blood count can give some indication whether it's bacterial or viral. Procalcitone is a better marker and more expensive. Better marker for bacterial infection. I mean, it became popular because in COVID, you get some high CRP values, but it's a viral infection. Then differentiate infection from Polonizing flora. Polonizing flora is little bit different from your resident flora. I mean, on your skin, you have some flora. Then because of the antibiotic pressure, there are some organisms inhabiting certain sites. So colonizing flora is a common problem. That is why wound swabs are unsatisfactory, because it can give this colonizing flora. You try to treat it with these ABST reports. Cellulitis, you don't get positive cultures if you are taking a swab culture, that is skin swab. And blister fluid is actually due to toxin of the organism acting on epidermis, raising and collecting tissue fluids. Very rarely you get some significant isolate from blister fluid. But pus is a better sample. Most of the time, surgeons drain, but don't send the sample. Later on, when the patient is not responding, they send either drain fluid or wound swabs. This is a common mistake. Candida species in sputum and urine means selected flora due to antibiotics. This is not an indication to treat, right? You try to correct the underlying risk factors like broad spectrum antibiotic omitment, control of diabetes, removal of urinary catheter, etc. Right? I mentioned this earlier, drain fluid cultures are not the actual pathogens. Bronchoalveolar lavage is a better sample compared to sputum. Sputum may not be a good sample. Go for guidelines. We have in the country national guidelines for empiric therapy. It's being reviewed these days. That's why I don't put the picture of the book, or there's little app also you can download to your telephones, cell phones. You can use that. Cellulitis is treated to cover Staph aureus and hemolytic streptococci. So you need a beta-lactam and protein synthesis inhibitor. Beta-lactams act by breaking the cell wall. So all these toxins produced by the organism flood the bloodstream. To prevent that, you give a protein synthesis inhibitor like aminoglycoside or clindamycin, which act on ribosomal level, and all toxins are proteins. So if you can stop protein synthesis, good, you will reduce the amount of toxin. In necrotizing fasciitis, you need anaerobic cover because there's necrosis. Otherwise, cellulitis, you don't need anaerobic cover. But it's some people just add metronidazole as a habit. You need to add methicillin-resistant Staph aureus cover if there's a poor response or risk factors like previous history of colonization due to eczema, skin conditions, things like that. And correction of underlying risk factors are very important, especially control of diabetes, vascular insufficiency. These things also need to be addressed at the same time for you to get good results. Antibiotics are not the only way of approaching these. This is I'm little more than something, abrasion, not, I can't call abrasion, but there's a skin loss. This is a 8-year-old little girl who fell from her bicycle. She came to GP with swelling and redness of the edges of the wound. You see, ICRP and WBC. Why is this? I mean, this is disproportionate to the injury. I mean, even now, this can be managed with the beta-lactam, like fluproxylene, with some protein synthesis inhibitor, right? This is because these organisms produce toxins which directly act on bone marrow and release immature neutrophils. So don't panic because of these reports, but clinically assess the patient. You are the people who will be part-time GPs, so it's better to tell you these things. This is a chronic ulcer from a post-renal transplant lady. She has come to health sector several times before plastic surgeon and microbiologist address the issue. We sent many investigations and one gave us the answer. The tissue samples and antigen detection gave us that this is Cryptococcus neoformans. No amount of antibiotics will not sort out this. because it's a fungus. So this type of complicated patients, you need multidisciplinary approach, not for GP to do wound dressings. Chronic wounds, if not progressive or run in a temperature, no need of systemic therapy. You try to address it with rotational antiseptics like povidone iodine, 1% acetic acid. There are many commercial wound dressing available, silonitrate dressings, Acticode dressings. I mean, depend on the type of wound and culture results you can decide. Wound swabs is not useful, but in chronic wounds, gram-negative cover may be useful. Not for acute wounds like that little girl, right? Those are mainly staph and hemolytic Streptococcus pyogenes mainly. Here, the correction of underlying risk factors are more important. If the patient is having MRSA, please decolonize this patient. Otherwise, you cannot successfully treat because he will get reinfection. So it's very important to go for source control in treating infection. For example, a patient with acute abdomen, without source control, you cannot achieve control of sepsis. Surgeon has to open it and address the problem. Urine infections with obstructions, again, you need GU surgeon to put a stent and arrange the proper drainage. Colonized central lines, vascular catheters, implants, they need removal. Otherwise, it's very difficult to treat the infection. So source control is one important thing. I have taken this from an American guideline. So they specifically mentioned this and they give the evidence as grade 1C. I mean, grade 1A is the best. A specific anatomical diagnosis of infection requiring consideration for emergent source control be sought and diagnosed or excluded as rapidly as possible. An intervention be undertaken for source control within the first 12 hours after the diagnosis is made, if feasible. So there is a little caveat. When infected peripancreatic necrosis is identified as a potential source of infection, definitive intervention is best delayed until adequate demarcation of viable and non-viable tissues has occurred. And now they go for interval appendicectomy if there is an abscess formation. Acute appendicular rupture, yes, surgery, but appendicular abscess also now they go for delayed opening. Sometimes you look at the ABST, it is resistant, but the antibiotic you are giving, patient is responding to the antibiotic you are giving. So in some instances, concentrations in the target site help to overcome resistance. For example, in urine, beta-lactams, especially beta-lactam inhibitor combinations like picacidin clavulanate, coamoxiclav, piperacillin tazobactam, they give even good results for resistant isolates. Your ABST says only sensitive meropenem, but your patient is responding. Quinolones too can give good concentrations in urine to overcome resistance, but this is as not good as above. Local preparations like eye drops or ear drops, you don't need to consider the ABST. They achieve so high concentrations at the site of infection because we do a certain number of bacteria that is standardized for bloodstream infections. Systemic therapy. not for these local therapies. So don't look at the ABST if you are using eye drops and ear drops. Same about antibiotic nebulization. For severe pneumonias, especially in ICUs, we nebulize aminoglycosides. Aminoglycosides are poor penetrators of lung, but when we nebulize, we are giving very good concentration to the site of infection. Only thing you need special delivery mechanism, special nebulizers for antibiotic nebulization. However, please don't systemically using useful antibiotics in local preparation. For example, eye and ear preparation containing gentamicin, please don't use, because that will encourage development of resistance. And always try to treat the correct duration. For meningitis, it depends on the pathogen. If you don't know the pathogen, you need at least 10 to 14 days of intravenous antibiotics, not oral. And when the patient is responding, don't try to reduce that high dose, because inflamed meninges allow penetration of antibiotics into CSF, but when the inflammation goes down, the penetration becomes more and more difficult. So don't reduce, but start and finish with the same high dose and intravenously. This is true about endocarditis as well. Bone and joint infections, endocarditis, deep-seated abscesses, you may need 4 to 6 weeks of therapy. Pyelonephritis, 10 to 14 days of therapy. If it is sensitive to ciprofloxacin, you can go for a shorter course if it is the first infection, first pyelonephritis attack. Hemolytic streptococci, even from throat swab or skin wound, at least give 10 days to remove, eradicate the organism. Staph aureus bacteremia, give 14 days of antibiotics and make sure that you repeat the blood culture during 3rd to 5th day of infection to make sure that you have cleared the bacteremia, and you may have to do echocardiogram and eye referral to exclude complications. It's notorious to give endocarditis and endophthalmitis. Pneumonia, if you know the pathogen, yes, but otherwise, it depends on the patient's clinical response. Mucormycosis, something not that uncommon in this COVID era. You need amphotericin B, and these patients are misdiagnosed and come to the correct unit, ENT unit, after very long delays. It's actually pathetic. I saw a patient recently who came with 5 cranial nerve palsies. She has lost vision of one eye, went to the same person with the lowering of sight in the other eye, but no CT done. So these are actually due to lack of awareness. In melioidosis, Burkholderia pseudomallei is again a problem in Sri Lanka. You need to stress the patient need to continue eradication therapy, because eradication therapy is oral therapy given for 3 months, mostly cotrimazole. So you need to stress that before sending the patient. However, patients with neutropenic sepsis or a patient slowly recovering or infected with multi-drug resistant organisms, patient in intensive care units or undrainable collections need longer duration of therapy. You need to think about concentration at the site of infection in certain instances. Meningitis is difficult to treat because of the blood-brain barrier that prevent achieving good concentrations. All antibiotics you can divide into 3 groups. Good penetrators of blood-brain barrier. I have only one example, chloramphenicol, no longer used. Then concentration gradient. All your beta-lactams come there. Then poor penetrators. Your macrolides, aminoglycosides are in that group. However, in neonates, blood-brain barrier is not developed, so you use cefotaxime and gentamicin to treat neonatal meningitis. Beta-lactams reach CSF when meninges are inflamed. Always remember, meningitis is treated with the highest dose, 2 grams IV BD if it is ceftriaxone, if it is cefotaxime, another dose. Cardiac valves are not vascularites. So to get the antibiotic concentration, you need higher concentration and longer duration. Bone infections, you need to treat with antibiotics which give good bone concentrations. I have mentioned a few here, but if it is MRSA, you need to work with the microbiologist. Prostate is another place, very poor penetration, and only the quinolones and 4-triamoxole give good penetration. When you are selecting, go for proper combinations. Don't try to give cloxylene, amoxicillin, 2 beta-lactams. Try to combine beta-lactams with synergistic combinations like aminoglycosides and quinolones. But for cellulitis, don't combine flucloxacillin with ciprofloxacin. Strep cover or staph cover is poor. Always go for an antibiotic which gives good concentrations at the site of infection. If you are not sure, use the institutional guideline or national guidelines for treatment, because when you are treating gram negatives, it's very difficult to predict the sensitivity. There's a circular about red light antibiotics. Most of these red light antibiotics are intravenous, but there are few oral antibiotics like levofloxacin, linezolid, cefixime, and these antibiotics are antibiotics you need prior approval from microbiologist. There are some common errors. A lot of people write cefotaxime dose for ceftriaxone. That will be toxic. And ceftriaxone is given 2 grams IV once daily, not 1 gram BD. One advantage of ceftriaxone is it's once daily dosing, but in Sri Lanka, it's not effectively used. Aminoglycosides act with the highest concentration. They act with the peak. So you need to give once daily dosing. And if you give your aminoglycoside for 48 hours, once daily, 48 hours, you don't need blood levels. You can give it without considering blood levels. You know, it's very difficult to get blood levels for aminoglycosides. However, remember, aminoglycoside dose like 5 milligram per kg gentamicin or 15 milligram per kg amikacin is calculated for lean body weight, not the actual body weight. For flucloxacillin or cloxacillin, 1 gram 6 hourly at least needed to cover Staph aureus and beta hemolytic streptococci. Your 500 6 hourly Mickey Mouse dose will not cover streptococci. That's one reason why your failure of treatment of cellulitis. And in morbid obesity, you need to go for dose adjustment. In renal impairment, for 48 hours, you can give beta-lactams without adjusting, but then after that, you need adjustment. De-escalation is called when you start empirically broad-spectrum antibiotic in severe sepsis, later on going to step down to a narrower spectrum antibiotic is de-escalation. So in this guideline, it says empiric combination therapy should not be administered for more than 3 to 5 days. De-escalation to the most appropriate single therapy should be performed as soon as the susceptibility profile is known. To do this, you should have sent the cultures before starting antibiotics. Otherwise, it will be difficult. Then, when to start oral antibiotics? I would say as soon as patient can tolerate. These antibiotics like quinolones, clarithromycin, fusidic acid, linezolid, metronidazole, azosa, fluconazole, itraconazole, voriconazole. These have good oral absorption or bioavailability. For example, clarithromycin IV and oral dose is same. That is because of good bioavailability. Linezolid 600 BD oral, 600 BD IV. Metronidazole 500 TDS IV, 400 TDS oral. Like that. Actually, going with oral is much better. You can use oral treatment even through NG tube, because antibiotics like clarithromycin or fusidic acid IV preparations can cause a lot of thrombophlebitis. When you need good veins, you can't afford to destroy them with thrombophlebitis. This is something I want to stress, right? Sometimes I get calls. Madam, he is sensitive to this, he is having allergy to this, he is having allergy to that. Sometimes there's nothing that we can give. HO has not taken a proper history. I mean, even when you refer to the microbiologist has to treat with the same available antibiotics. So you need to take a proper history and don't write on the diagnosis card without good evidence, right? Because when you say allergic to penicillin, no one gives anything till consultant or microbiologist start antibiotics. And in gram-negative sepsis, beta-lactams are the best antibiotics you can give. So you deprive the patient of that. I have got leptospira isolate only once. It was because patient was not started on anything till I saw the patient because she was allergic to penicillin. So I was able to send the culture and start doxycycline. So if a patient tells you that they are allergic, ask for which antibiotic and ask the relation to the antibiotic. I mean, immediately after taking the antibiotic or 1 hour after the antibiotic, 1 or 2 days on the treatment, because anaphylaxis usually you get within the first hour of starting antibiotic, IV antibiotics. Oral, you have to think about absorption. Then ask, what did you have? Shortness of breath, lowering of your blood pressure that you feel faintish, or just itching, rash. You need to clearly differentiate what is the problem this patient is having. If it is anaphylaxis, no beta-lactams, right? And you need to refer these patients for further investigation to the immunologist, there are 2 stations, Jawaharlal University Clinic and MRI Immunology Clinic. Then they can investigate and if necessary, desensitize these patients for certain antibiotics. That will help you to start narrow spectrum antibiotic. But if it is true penicillin allergic anaphylaxis, you can't even give meropenem. Some of these reactions in patients are related to the time taken for administration. For example, ceftriaxone 2 grams, you have to give like over 30 minutes. Currently available coamoxiclav, there's special instruction to give it at least over 30 minutes, even in the patient information leaflet, and it was a circular to use burettes and give this antibiotic. Vancomycin, you have to give slowly. It has to be over 100 minutes, slow infusion to avoid the development of red man syndrome. It's a very characteristic side effect. If you give it properly, actually now the incidence are much lower because now the penetration, now the preparation purity is much better. Earlier, vancomycin was called Mississippi mud. There's a question. If patient has allergy symptoms to drugs, not an anaphylaxis, still we continue that drugs or we have to contact microbiologist. Actually, if you can control it with some antihistamines, you don't need to discontinue or no need to contact microbiologist. Right? So we come to prophylactic therapy. You need to recognize the indications. For example, splenectomy patients are started on penicillin 250 BD for 2 years after splenectomy. That's a very clear indication, and you can give. And tooth extraction needs cover in certain conditions. And if a patient had former infective endocarditis, they need prophylaxis. Yes, another chat. What are symptoms and signs to suggest bacterial respiratory infection over viral infections? That is difficult to say, right? But if more than one person affected in the family, usually it's viral. And when you send the counts and CRP, you get some idea this is viral. That's why I said use some judicious investigations. If you suspect dengue, you can send NS1 antigen. It's something which is positive very early. And not only respiratory infection, most of the diarrheal illnesses are viral. Don't prescribe antibiotics. Tell them to take just these home remedies. Coffee, Vediha alkandar, garlic and ginger. These things will work because those are self-limiting. Even in UK, Campylobacter and Salmonella, non-typhoid Salmonella are not treated unless they are giving blood and mucus diarrhea or in a young child. Microbiology laboratory will not issue the ABST report. There are ABST for GP also done by the microbiology lab. GP's website cannot see Campylobacter, non-typhoid Salmonella, ABST. They know only these two are the isolates. Then they will not start antibiotics. It's that simple. But our people lack patience. They want one shots. Most popular GPs, one shot. Types of antibiotic for prophylactic therapy. well-absorbed antibiotics like ciprofloxacin and coamoxiclav, you can use over IV. Prophylactic, there is a duration. Single dose aminoglycoside, but beta-lactam, you repeat. You need to clarify about the reasons and duration of prophylaxis. Don't give it unnecessarily. I want all of you to remember this. We have eradicated malaria, but we have the vector in our country. So take a good history. All our malaria cases are imported cases. But because we have the vector can feed on the patient and transmit it. So our malaria eradicated, eliminated label is in your hand. If you are good and detecting all these imported malaria, we are safe. Don't forget malaria. I was going to give you some time to ask questions, but you are very active. Color of sputum, no. And I want all of you to do this notification of communicable diseases. On the reverse side of this form, there is the information about the diseases you have to notify. Please do this because this only helps us to have some idea about the problem, right? Don't forget to fill the notification form. As house officers, it's your duty. So my message to you is antimicrobials are not a panacea for everything. They have different modes of action. They have different pharmacokinetics and pharmacodynamics. They have different instructions for administration and they have adverse effects. So you have to be very careful about these side effects, toxicity, and their effect on changing the flora, causing antibiotic-associated diarrhea, Clostridium difficile associated diarrhea, and most of all, the resistance. When we did the study on Clostridium difficile diarrhea, there's another question. Madam, can height of fever spike and gap between two fever spikes give an idea of bacterial versus viral respiratory infections? Can't say it's 100% good, this thing. Usually viral, you get continuous like fever, but even bacteria can cause it like that. If you have seen strep pneumonia, you will realize what I'm telling you, right? When we did it in 2009 or 10, we could get only 4 patients by doing it in 3 hospitals, National Hospital, Colombo South, and Teaching Hospital, Karachi, only 4 patients. But now we see more patients. This is because of higher use of antibiotics, especially these broad spectrum antibiotics like carbapenems. Earlier, this was a problem for Western countries, but not for us. But now it's a problem for Sri Lanka as well. There is a form with chief pharmacist if you want to report any adverse effects due to your antibiotics. Please use it without just complaining. I mean, you just tell it everywhere, but you are not doing the official thing so that we can investigate it. So this is sort of my last slide. I'm asking you, have we achieved any progress over this antimicrobial resistance? I have few examples for you. When I was a medical student, 3rd year medical student, Fancida is a combination therapy for malaria. falciparum malaria. This was brought to the reserved group. So we have eliminated, before elimination, we were able to remove falciparum malaria. But if you go into the region, Southeast Asia region, you will see how resistant is. I don't know whose mic. Falciparum resistance. So we have achieved something by doing that. And anti-TB medication. When I was a microbiologist in the early era, I used to see the sputum AFB positive ones. I used to start after giving a good chat to the patient about importance of continuing the therapy. But I don't do it now because we have put anti-TB medication under chest physician. I'm in 100% agreement. That's how we have very low incidence of multi-resistant TB. It's called. Okay, there's another question. We have national guideline for use of the cholesterol. Sorry. Then we have certain death review meetings for some infections like leptospira, TB, dengue. Other than anaphylaxis, you can give. Right? Anaphylaxis, avoid all beta laxatives. Even your meropenem is not safe here. Then we have perinatal mortality morbidity meetings where you look at neonatal deaths. And we have red light antibiotics. When the WHO send the form every year about antibiotic stewardship, this is the only thing we can write. Then we have therapeutic committee meetings where we discuss about antibiotic shortages, withdrawal, all that. But it's only a very, very small achievement. But this shows you that by limiting prescription power, you can save medication. So we need to develop antimicrobial stewardship committees. Ministry is considering this. It tried once, but we could not properly establish antimicrobial stewardship committees. And with that, we maybe achieve a bit more progress. If you go to UK, you cannot write ciprofloxacin. Microbiologists will not even bat an eye about that. You will be brought to line by the pharmacist, right? So if you want to migrate, just be able to feed BNF properly and write a proper prescription rather than write whatever comes to your mind, right? So thank you very much for staying with me. Most of you have stayed with me. Now you can direct your questions. Unmute and ask questions if you want, or type on the chat box.
Thank you very much, Madam, for that powerful lecture on antimicrobial resistance. So if you all have questions, please can unmute and ask or chat in the chat box. At the meantime, we will have a 50 minutes tea break from 10 to 11 to 11:15. So Until that, if you have a question, please ask.
Any questions? Or is it clear? You will be prescribing what your consultant will tell you. But remember some of these things at least for your future. And as I told you, most of these things need good infection prevention activities, like hand hygiene is very important, and vaccination. If you have not taken hepatitis B or COVID, please don't wait. You need to go for the vaccines. Vaccines are one way of facing resistance. Cloxilline or flucloxilline, you need to give 6 hourly. Its T half is very short. Even oral, even IV, it's very important to give 6 hourly. Don't think because it's flucloxilline, you can give TDS. It's cloxilline only 6 hourly. Both 6 hourly medication. And advise your patient regarding the time to take. Cloxilline, flucloxilline, you need to give half an hour before meals. But if it is co-amoxiclav, you have to give it, or amoxicillin, you have to give it after meals, like half an hour after lunch, after meal, right? These are important. And IV administration time in Sri Lanka, we had some deaths due to rapid administration of ciprofloxacin. That was investigated then. Proven it was the administration speed which caused it. If you suspect something, please inform. Country has the ability to assess microbial activity of these antibiotics. There's a national quality control lab, so we can send the samples. Antibiotics are removed through 2 main organs. One is kidney, one is liver. Some antibiotics are removed by metabolization in liver, some through kidneys. So depending in the end organ, you treat these patients. For example, if it is liver failure patients, you go for cefotaxime. But if it is renal failure patients, you prescribe ceftriaxone. Then shall we stop for your tea? Thank you very much. Try to remember at least few things from this lecture for your career.
So we'll come back after the tea break. So next lecture is by Dr. Dhammika Vidhanagama, consultant microbiologist at LRH, on the topic of microbiological aspects of sepsis. We can start, ma'am.
Okay, thank you. Good morning, everyone. We will just have 1 hour to talk about sepsis. And I'm sure we have learned about sepsis as final year medical students and before that also many times. I think since it's very important, reminding you again will not be a waste of time. We will mainly focus on microbiological aspects here because you will be dealing mainly with those at this point. But other colleges, I'm sure they will teach you about the more details on the management of sepsis. So we will talk about sepsis, what is sepsis, and a little bit about the disease burden, and remind you about how it happens, how does it happen, and most important thing is improving outcomes. A little bit about performance improvement programs, mainly early detection, appropriate management, identifying and controlling of sources, and prevention. So what is sepsis? So we all know it's a life-threatening thing, which is related to dysfunction of organ systems. It could be one system, it could be multi-organ dysfunction, but it is life-threatening. And what is it caused by? It's the host response to an infection. We all get infections, but we don't. All of us don't go and get sepsis, but this is a dysregulated host response to infection, and it is a medical emergency. So you will see these patients in emergency rooms, in your wards, in ICUs, and sometimes maybe in the community also you will be finding a patient who has not presented to hospital early enough. So wherever you find them, you consider it as a medical emergency. And we know that sepsis and septic shock causes morbidity. Millions of people are affected globally each year, and a considerable proportion, 1/3 to 1/6, may die due to sepsis. And what happens during infection and sepsis? We know that when people have infections, sepsis is the primary cause of death, causing due to infections. So it doesn't happen in a single step. There are several steps. At the beginning of an infection, there should be some transmission, and there should be a portal of entry, and you get the infection. If your body is not strong enough to fight, you will be infected and having the disease. And if the disease is untreated, people will go into sepsis. And if the sepsis remains untreated, it will invariably lead to death. So there are many steps where you can intervene during this process, and early recognition is the only step that will help you in the management, because when the sepsis process starts, it goes as a cascade. It's very difficult to stop once the process of sepsis starts. So early recognition and management is the key to preventing morbidity and mortality. And we have to remember, sometimes this sepsis-induced organ dysfunction may be occult. You may see an infection, but you may not detect an overt organ dysfunction. But when you have think of infection, you have to look for organ dysfunction as well. And on the other hand, there may be sometimes you detect organ dysfunction first, a new onset organ dysfunction, which may be related to an unrecognized infection. So if you have organ dysfunction, you look for the causes for organ dysfunction. It could be sometimes infection. And not all infections lead to sepsis. We know that if the organ system is able to contain the infection without a dysregulated systemic host response, it will be all good for everyone. And why do we get sepsis in some people? there are many different clinical and biological phenotypes of sepsis, and it will depend on host factors as well as the factors related to the infective agent. Host factors could be pre-existing acute illness, so long-standing comorbid conditions, so medications, so interventions, many different factors in the host, as well as the infective agent, how virulent it is, and how many organisms are getting into the system. The inoculum also might be important in this case. So looking at the definitions of sepsis, I'm sure you have seen the definitions. This is the sepsis 3 definition. These have evolved over time. In 1991, they started with sepsis 1 and then later on. Finally, these are the definitions we are using at the moment. These are sepsis 3 definitions. This is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So how do you know when it is life-threatening? You can see, you can assess the organ dysfunction. How do we assess the organ dysfunction? They are using a score here, also SOFA score. I'm sure you have learned about the SOFA score. We'll describe it a little later, but all the details will be given to you when you start programs with the resuscitation and CPR programs. They will be discussing this. So first stands for sequential organ failure assessment. So if there are more than two or more points later on, you may do it daily or on the admission, maybe on admission to emergency, on admission to the ward, on admission to the ICU. So you have to know previous score, or if you don't have a previous score, you assess it as a 0. And if there are 2 or more points rise in the score due to the infection, you can consider it as organ dysfunction. So what is septic shock? Now we know in this new criteria, we do not have the category called severe sepsis. It goes from sepsis to septic shock. Earlier definitions by earlier sepsis definition, there were 3 categories: sepsis, severe sepsis, septic shock. But now we have only sepsis and septic shock after 2016 definitions. And then we see septic shock as a subset of sepsis. The patients already have sepsis. They fulfill the sepsis criteria, but they have profound circulatory, cellular, and metabolic abnormalities, which substantially increase mortality. So when we have considered according to definitions, these are 2 criteria: persisting hypotension needing vasopressors to maintain MAP over 65, plus serum lactate levels above 2 despite adequate volume resuscitation replacement. So when these criteria are considered, they have calculated the mortality in this subset of people will be exceeding 40%. So this is called septic shock. So what is the disease burden? Why should we talk about sepsis so much? Because it causes a considerable burden of disease and death. Almost any infection, we've all worried about COVID-19 during last 2 years. The whole world was changing due to this thing, including COVID-19. Any infection can lead to sepsis. So do we treat each and every patient with infection as sepsis? No. So we have to know what is sepsis and what is the disease burden of sepsis, not infection. So sepsis disease burden was assessed by WHO in 2017. So it was around nearly 50 million cases of sepsis, estimated cases of sepsis in 2017, with 11 million deaths. It accounted for 20% of all global deaths. And among these 50 million, 20 million were in children below 5 years, with nearly 3 million deaths among those kids. So it is a significant morbidity and mortality, and there are significant regional disparities also. Most of these, 85% of this disease burden was estimated to be in the low and middle income countries. So does that mean only the low and middle income countries have this? No, but we see USA have their assessment. The CDC says about 1.7 million adults annually develop sepsis with 270,000 deaths. And then 1 in 3 people who die in a hospital will have sepsis. Luckily, most of those cases are not acquired in hospitals. So 87% of cases acquire it somewhere in the community, and it was a very costly affair, costing about billions of US dollars. So why and how does it happen? We all have seen this diagram, how the body responds to any insult. We have, when there is an infection, we have the organism releasing different types of molecules. So there are patterns in these molecules called pathogen-associated molecular patterns. And when there's an injury, there are danger-associated molecular patterns. Those patterns are recognized by the immune cells by pattern recognition receptors, and then there will be a response, immune response. When this immune response is adequate and it which is all controlled, it will cause a recovery. It will cause the patient, help the patient to recover from the infection. But when there's a dysregulated immune response, there will be organ failure with the risk of death. So how does this all happen, and why do some people go for sepsis? And there are genetic factors, age, comorbidities, as we discussed earlier, and the pathogen plus the environment. Many different factors will support this dysregulated immune response, and in different people it will be a different causation. So it's an all complex setup. I'm not going to describe this slide, but we know, we have learned immunology and pathobiosis of sepsis. There are many different cells, many different chemicals, many different cytokines getting involved in this pro-inflammatory mediators and anti-inflammatory mediators. There is a balance which is disturbed during sepsis, and sometimes there may be unique organisms like MRSA. We have MRSA, we all of us think it's a hospital acquired thing, but as we now know, there are community acquired MRSAs which are very virulent. So they acquire it in the community, and they have this special single, there are multiple pathogenic mechanisms, multiple virulent factors, but there is this thing called PVL, Stanton Valentine leukocidine. This will cause, even a single virulent factor can act in many different ways and cause release of cytokines, epithelial damage, and cell death. So so that will all depend on the organism affected. Organism infecting the patient, and any type of infection. It's not only bacteria, viruses or fungi can cause this picture. The most commonly affected sites could be in the community, could be a pneumonia or a UTI, maybe a digestive system infection, bloodstream infection. If it is a patient with wounds or burns, you have seen people dying with infected burns. And sometimes if the patient is in hospital, catheter sites may be a site. So we can divide it as community acquired sources and healthcare associated sources. Community acquired sources could be again pneumonia, intra-abdominal infections, which we have listed, skin and soft tissue infections if the patient is coming with severe cellulitis or necrotizing fasciitis, that could lead to death. And sometimes there may be pelvic infections and fungal, viral. Sometimes there may be instances where we can't identify the source. You will have the patient with sepsis or septic shock. It's very difficult to find the source. In a healthcare system, we will have patients in the ICUs with ventilators. So they develop ventilator-associated pneumonia. If they have central lines, they have central line-associated bloodstream infections. And there may be people with catheters, catheters developing infections called catheter-associated UTIs. And sometimes surgical site infections may be due to organ space infections or deep incisional infections. They could be the source of sepsis for the hospitalized patient. So these also cause considerable morbidity and mortality due to healthcare provision that we give in the hospitals. It could be in the hospitals, maybe a patient with a central line who goes home and comes in for a hemodialysis. Ambulant people, they have their central lines, come for dialysis, then they are more prone to get infections to their central lines. So sometimes they may get MRSAs, and they may even, if it goes undiagnosed, they may end up in sepsis and come to your ward. So what are the risk factors in the host? It could be the extremes of age, maybe the neonates you have seen, the premature babies in the PBU, and there are surgical populations among these children. The cardiothoracic units will have many children with cardiothoracic surgery. And on the other side, there may be other populations like over 65 years of age, elderly. They are more prone to get infections and thereby they are more prone to get sepsis. And diabetic patients, CKDs, liver failure, and all those people, due to their impaired immunity, they will be more prone to get sepsis. And you have seen trauma patients, so polytrauma patients, when they have multiple factors affecting their immunity and immune suppression due to trauma, and then the medical management, surgical management, they are more prone to get infections and sepsis. And when they are admitted to ICUs, we have multiple devices, and when they have a longer hospital stay and multiple invasive devices, those are the portals of entry for organisms, and they will cause sepsis. And any reason compromising the normal immune system, may previous use of chemotherapy, antibiotics, corticosteroids, maybe bone marrow transplants, kidney transplants, all those patients are at a higher risk of developing sepsis. So what can we do to improve the outcomes of sepsis? As we said earlier, we have early identification. Early identification is the key for the management. And then when you manage appropriately in the initial hours after the development of sepsis, you can have better outcomes. So we have to have sepsis performance improvement programs in healthcare institutes, which will constitute several aspects. Maybe you have a program for screening of sepsis, screening for sepsis. We will talk about screening a little later. And then you have to have educational programs, because the patients also should be educated to come to the hospitals early enough for us, for the systems to diagnose them early. And there should be some metrics, some measurements of your performance. Any performance improvement program will not function without metrics. So you have to measure certain aspects of your program, maybe the sepsis bundle performance, how people adhere to sepsis bundle, and the patient outcome monitoring. So maybe the process monitors, maybe the outcome monitors. So there should be some measurements in the system. And then does it stop at the metric level? No, we have to make some action. When you do measurements, you have to do some interpretations and take appropriate action to improve the adverse events that you have identified. So first of all, we have to think, is it sepsis? When your patient comes to you, you have to think of sepsis. So look for symptoms and signs, and screening tools can be used, and look for evidence of infection, look for evidence of organ dysfunction. And we have to also remember, it's not always sepsis which will cause this picture, this clinical syndrome. There may be other things which will cause this, which we call as sepsis mimics. So how do you educate patients? This is an important thing for your patients to know, because some of you may end up in public health looking at the big picture. Now it's important for people to know what is sepsis. So it's we have to describe in simple terms it as an extreme response to an infection, and they have to know that it is a life-threatening medical emergency. And then they have to identify that there is an infection, when to seek treatment early, because if they have infections in the lung, urinary tract, GI tract, if they detect that early and present, that will be better for them. And they should know, without timely treatment, sepsis can rapidly lead to tissue damage, organ failure, and death. So all these things our patients need to be educated on. And when you look at these symptoms of sepsis, I'm not going to go through this list, but you have seen patients so far that is there any pathognomonic sign of sepsis? No, they will come with all those things, very general, diverse symptoms, fever, chills, shivering, some of them may be disoriented, many different things they will come with, fast heartbeat, muscle pain, discomfort, many different presentations. And septic shock also the same things. they will come with severe breathlessness. There may be symptoms, maybe more severe in a patient with septic shock. Sometimes they may be unconscious when they come to you, confused or disoriented. So we know it's a diverse symptomatology, and then in children it is worse actually, because they will not come and tell you what has happened. So we have to go by temperature, about 38 if it is below 3 months one, about 39 if it is more than 3 months. And these are some criteria which we have taken from international documents. So there are, like whenever you go for the practice, you have to go by the institutional criteria. So the child is usually not encouraged, cannot be encouraged to show interest in whatever the things they are doing usually. So parents should be taught on diagnosing the likelihood of sepsis or infection when they come to maternity units, when they are during their pregnancy, when they do educational sessions, or when they go home with their babies, they will have to be taught. And some children may have difficulty in breathing, more like grunting and all those things. The parent, if the child is at home, the parent should be able to identify. And then feeding is another thing that you have to look at, and no interest in feeding in a neonate, or not taking in fluids at least, and sometimes diarrhea, vomiting could be things. And people may come to you with different things like sunken eyes, floppy babies, weak, whining, or poor cry in the patient. If it is an older child, maybe confusion, irritability, and neck stiffness, and sometimes oliguria, anuria may be a presenting symptom. So with all these different systems, how do we diagnose sepsis? Because there can be many other reasons for those symptoms, as we all know. So screening tools have been developed for detecting sepsis, and these have been changing over time. Like earlier, we were talking about systemic inflammatory response syndrome, SIRS criteria. We will describe these things in a little bit. And then there was this quick SOFA, because then people said after 2016, they abandoned SIRS and went for Q-SOFA. And we talked about SOFA earlier, and then there are these not so infection specific criteria as well, which will detect people who are likely to deteriorate on admission, maybe during ambulance, transport, maybe in the community. You may apply some criteria which will not be very specific to infection or sepsis. They are the general criteria. Those are those are early warning scores, national early warning score and modified early warning score. I'm sure you have learned about these things. So these screening tools, initially we were thinking of SIRS, and 2016 SIRS was discouraged and we were asked to follow Q-SOFA. Now in the 2021 guidelines by this Surviving Sepsis campaign, they recommend against using Q-SOFA. And as a single screening tool, if you use only Q-SOFA, you may miss some patients with sepsis or septic shock. So they are asking us to look at other criteria like SIRS, SOFA, NEWS, or MEWS. What is the SOFA score? We all know it's a sequential organ failure assessment. It is in the definition of sepsis. And it was initially developed to assess organ dysfunction at a population level. It was a way of looking at the big picture initially, but later on they found that it can be used as an important tool to define clinical condition of individual patients as well. And then in clinical trials also, it was used to assess response to different types of therapies which are being trialed. And now people are using it mainly for the daily monitoring of acute morbidity in patients in ICUs. So this is the SOFA score. I'm sure you have seen this. It looks a bit complicated, but we know we assess 6 parameters. We assess 6 parameters and assign 0 to 4 for those 6 systems. Those are the main systems where organ dysfunction can be identified, and then we can assess, give a score and assess whether there are 2 or more points. So the main systems are the respiratory system. We use the oxygenation index or PF ratio. And then CNS, they use Glasgow Coma Scale, and CVS, MAP and administration of vasopressors, liver bilirubin, then coagulation with platelets and kidneys with creatinine. Though you can just remember the zero score. If it is PF above 400, platelets above 150, bilirubin less than 1.2, MAP above 70, and GCS 50, and creatinine less than 1.2. It's all good. Patient is good. And if there is any deterioration later on, giving you a score of 2 or more, you have to be thinking of possible sepsis. And we know that all these SOFA things are very difficult to assess because you need several investigations here as well. That's why they developed this Q-SOFA as a bedside tool. So this was given in the 2016 guidelines, the quick SOFA. Very few bedside assessments can give you this Q-SOFA score. And if it is more than 2 or more, then that will suggest a greater risk of morbidity or mortality. So this is the quick sequential organ failure assessment score, respiratory rate about 22, which you can easily measure, since BP less than 100, and altered mental status. So if there are more than 2 or more, with a 3 to 14-fold increase risk of sepsis and septic shock, maybe morbidity, mortality. So that was the one used earlier after 2016. Now they are asking us to use more of SIRS criteria. SIRS criteria also, I think you have seen this, body temperature 38, above 38 or below 36, tachycardia more than 90, tachypnea, this here now we are using 20 as the cutoff, or PSCO2 less than 32, and white count about 12, less than 4, or more than 10% Dan forms. So these are the criteria used for SIRS. So that was used earlier also. Now we are encouraged to use that also after 2021. Next, of course, this modified early warning score was developed in UK 2001 as a bedside tool. This is not infection specific. It's a tool to identify patients at risk for catastrophic events, including death, because you have to identify them early and give them a higher level of care. So it was earlier used in UK for medical admissions, and later on it was evaluated for surgical and emergency patients. There are things like EMUs where you administer this at the emergency room, and maybe ambulatory settings you may use. So different types of scores are there. So this will assess 6 vital signs. So it will again start with a score which will give respiratory rate, heart rate, SBP, and all those things will be assessed, including hourly urine. So this is a difficult thing that we have to measure urine output somehow. So this is difficult in some settings. And then how do you measure the consciousness? Here it is the unresponsive, responsive pain. This is AVPU measurement. If the patient is all alert, then it's all good. Again, it's a 0 score for alert, and all the normal things get a 0 score. If it is new vegetation, you give 1. Responded noise, you give 1. It's like that, different types of measurements on conscious level. This is used in some settings, but after 2012 in UK, this Royal College of Physicians, they developed this tool called NEWS, National Early Warning Score in UK, and that was used to improve detection response to clinical deterioration in adult patients. It's a key element of patient safety. Because why did they call it national? Because they wanted to standardize the use of this scoring system throughout their NHS trusts, acute care and ambulance settings. And in 2017, they modified that and called it the NEWS tool. So again, it's a 6 simple, routinely measured physiological parameters. So if it is a higher score, that will give some measurement of the deviation from the normal physiological levels. And if the patient needs oxygen, you have to add 2 to the score that you get. So this is the news 2 score. Again, if it is all normal, your score will be low. If it is 3 or more, you have to discuss with the senior colleague, and score above 6, immediate action should be taken. So all these things are wherever the settings that you go, which screening tools to adopt will be discussed by your consultants, and which level to alert. Of course, if it's a new score, which is again non-specific tool, but if these parameters are abnormal, definitely you have to take action. And okay, now we have seen the patient suspected. Now we know that the patient is having sepsis. So how do you manage this patient? So again, we are going back to this Surviving Sepsis Campaign 2021 guideline. I'm sure you all must have seen this. There are initial resuscitation, and there is a MAP target here to maintain a MAP above 65 over a higher MAP target. And then they recommend admission to ICU within 6 hours. And hemodynamic management, ventilation management, additional therapies, long-term outcome. I'm not going to discuss in this lecture, but I will be talking mainly about this treat the infection component, which is related to the microbiology aspects. Just a little mention about the initial resuscitation. This is the our one bundle, which includes 5 elements. So sure all of you know what a bundle is. Bundle is a collection of evidence-based practices which we practice together within a time frame. And here in this bundle, the time frame is 1 hour. So we have to do all these things within that 1 hour to resuscitate the patient. So since these are medical emergencies, you have to do all these things. So first one is the lactate measurement. It is about to you get to act on that, and then second one is blood cultures. Third one is broad spectrum antibiotics. So 2 and 3 we will be discussing further. And then how do you resuscitate with fluids, crystalloids and all, I'm not going to discuss. And the vasopressor use again will be discussed by other colleges. So we will discuss 2 and 3 of this bundle. And in UK they use sepsis 6 bundle. Yeah, there are 3 therapeutic elements, 3 diagnostic elements. So all 6 elements are in the bundle. So within 1 hour, you have practiced all 6 elements. If you do only one, it's not considered as a bundle. We were talking about measurements. When you measure bundle compliance, if you have done only 4 out of these 6 parameters, it will be taken as a non-compliance, because bundle compliance is an all or none one. If you do all 6, you are taken as compliant. If you don't do 1 or 2, it's a non-compliance. So here the difference is again, you have lactate, blood cultures, IV antibiotics, fluid management, and oxygen here. But here now oxygen and urine output measurement is there in addition. So once you have done your initial resuscitation, at the same time you have to think of the source and etiology, because you are asked to give antibiotics. So to give antibiotics, you should know which antibiotic. So for that we have to know, we have to diagnose this source and etiology, because the source could be some system, maybe a pneumonia, maybe a UTI, and etiology could be which organism. So we have to take again 2016 and 2021 SSC guidelines. They ask you to take microbiology cultures. Our one bundle will have blood cultures before starting antibiotics, and as soon as possible, and you never delay the antimicrobials for the sake of collecting specimens. I'm sure all the emergency departments and wards have the blood culture bottles. So we have to do this. So for identification of the possible source and etiology, your history examination will help you. Sometimes you will go for imaging, chest X-ray for the diagnosis of a pneumonia, and other tests like white count, CRP may help you. And then the blood cultures are essential in sepsis. And other specimens you have to collect for bacterial cultures and sometimes for fungal cultures. And if it is a patient with suspected COVID-19, you may go for antigen testing. And then if it is a pneumonia patient, there are urine antigen testing for Legionella and pneumococci. Sometimes antibody testing for if it is a patient with leptospirosis. You may take antibody testing for leptospira. Like that, you may have different investigations, but you never delay antibiotics for those investigations. When you have taken your blood cultures, within the first hour, you can go for antibiotics. And then there are these blood culture bottles. There are different types of blood culture bottles. Ideally, you have to take a set, but generally we give only one blood culture bottle. And then if it is a patient who's in hospital or coming from the dialysis unit and all with a central line, you need a couple of blood. You will be taught about this in the later lectures. If the patient is having a central line, at the same time, you have to take a blood sample, one from the central line, one from a peripheral vein. You have to collect similar volumes to those. And for the pediatrics, you have a smaller volume. This pink bottle is for pediatrics. Adult bottles are different. You have to collect bigger volumes. And other cultures, of course, depending on the system, whatever the system patient has, after your examination, if the patient is having a pneumonia, sputum cultures, later on you may even go for a bath. If it is a UTI, urine samples, skin and soft tissue infections, pus aspirates, abscesses, and all those things you may aspirate. If the intra-abdominal infection, you may take the patient to theatre immediately, and then you should take a peritoneal sample if there's evidence of bowel perforation. All those other samples you have to take for microbiology, bacterial cultures, for us to identify a possible organism and the sensitivity pattern to manage sepsis. So now when to give antibiotics? We definitely know it's after taking the blood culture. You don't wait for the other cultures, you give within 1 hour. But there are these 3 categories. Now we divide this into sepsis, definite or probable, lower column, possible sepsis, and then shock is present, shock is absent. So if there is shock, if it is shock, whether sepsis is definite or probable or possible, you give antimicrobials immediately within 1 hour. So if it is a definite or probable sepsis, even if there is no shock, you give antibiotics within 1 hour. And then we come to this last category when there is no shock, but sepsis also it's not definite or probable. So you do a rapid assessment. Go back to your history clinical examination. You may test for both infectious and non-infectious causes. You assess the likelihood of infectious causes within 3 hours of presentation. And then if you have concerns, within 3 hours, you give your antibiotics. So this is again the same thing I'm telling. Possible septic shock or highly likely within 1 hour. Without shock, again, if it is only possible sepsis, you may go for antibiotics within 3 hours if the likelihood of infection is higher. Possible sepsis without shock, again 3 hours. But if there is very low likelihood of infection and without shock, you may defer antibiotics while you are monitoring the patient and being ready to give antibiotics if you have any more doubts during the further assessment. So if the suspected sepsis or septic shock, you will continuously re-evaluate this person for alternative diagnosis, and maybe your diagnosis is a different one because this sepsis diagnosis is not a very specific one. So you may be able to establish another diagnosis, in which case you may have to stop antibiotics, but otherwise you continue antibiotics. And the use of procalcitonin, because that is an in thing, some people like to use this, but this 2021 guideline does not encourage early procalcitonin. They are recommending against procalcitonin, but they recommend further clinical evaluation at this stage. This is the early stage of sepsis. And we were talking about sepsis mimics. Actually, there are many other conditions. We know these overlapping areas in these things. There is infection due to many different organisms. There is bacteremia, because not all patients with infection and sepsis will have bacteremia. So your blood cultures may sometimes become negative, as you know. And then there is this SIRS category where the patient is having SIRS and evidence of sepsis, but it's not an infection. So what are those things? The trauma, burns, pancreatitis, and there may be other inflammatory syndromes like macrophage activation and all those rheumatoid syndromes and DKA, and sometimes there may be non-infectious febrile conditions that may mimic sepsis. So if you later on think that your patient is having some other diagnosis, you may stop antibiotics. And then you come to this question of which antibiotic to give. Everyone will ask you to give an appropriate antibiotic. So what is this appropriate antibiotic? So we have to go by clinical evaluation, and then how do you consider the likely pathogens? What are the bugs? You can't kill all possible bugs inside the patient's body. So you have to kill the pathogen. And then you have to think of this source of infection, and then the system involved, because you have learned all these things. If it is a pneumonia, what are the common pathogens? What are the common pathogens in UTI? Like that, you think of the likely pathogens and the host factors. If your patient is a patient who has had the bone marrow transplant, a son immunosuppressants, or a post-KT patient, then you have to consider that as well. And then when you give antibiotics, always think about the potential harms. If it is a patient with CKD, can your antibiotic worsen this problem? If it is a patient with liver failure, so you have discussed antibiotics earlier. So you have to think of potential harms. And if you give multiple antibiotics, you have the risk of Clostridium, this C. diff associated diarrhea, and antibiotic resistance, which we talk about always. So you have to remember the potential harms and always seek senior advice. And there are antibiotic guidelines. National level antibiotic guidelines are there to guide you, and then some of the institutions will have institutional guidelines to use antibiotics for this empiric therapy. So this is empiric therapy we are giving at the moment to target the most likely organisms and to reach the system where there is infection. And they say if they have a risk of having MRSA, what are the patients with risk factors? Those who have had hospital admissions and previous screenings positive for MRSA and all those things. A patient with a central line who had had a MRSA infection earlier, then all those people will need MRSA cover. But all the other patients, if they don't have any risk factors, we don't give MRSA cover. How do you cover MRSA? With the glycopeptide, which is vancomycin or teicoplanin, but we don't give it uniformly to every patient with sepsis or septic shock. And then if your patient, like whether to give one agent to cover gram-negatives or to give 2 agents. So if your patient is having a risk of having multi-drug resistant organisms, then your empiric therapy may have more than 1 gram-negative cover, but otherwise, what are the patients having high risk for MDRO? So those are the people who have had hospital admissions, had received multiple types of healthcare, many days in hospital, especially in ICUs, many different devices. Those patients you may give 2 agents to cover gram-negatives. Otherwise, if it is a person coming from community, even it may be septic shock, but you don't give without risk factors, you give only 1 agent to cover gram-negatives. And then again, gram-negative coverage, if you have the susceptibility, if your blood culture becomes positive with the sensitivity test, then you tailor the antibiotics according to the antibiotic sensitivity pattern. So that is the targeted therapy. Initially, we give empiric therapy. Now, when the ABST pattern is available, we give the targeted therapy. And whether we need antifungals, we don't go and give antifungal therapy to each and every patient with sepsis, but there are risk factors in some patients which will make them more vulnerable to fungal infections. If you take your patients in the PBU, babies, premature babies who have received multiple antibiotics and multiple interventions, maybe they are at risk of getting infections, who have been on multiple broad spectrum antibiotics and abdominal surgery. Like that, there are several risk factors to acquire fungal infections, mainly due to Candida species. And then maybe there are some patients, last few years we saw patients with COVID-19, like they were coming with this rhinocerebral mucormycosis, especially the diabetic patients. So like that, there are some risk categories who have a higher risk of having fungal infections. Among those people, the neutropenic patients, if they are on chemotherapy or due to their malignancy, so the conditions which will make them neutropenic, or again transplants and chemotherapy and all those risk factors. If they are having risk factors, we will consider antifungals in the initial empiric therapy. Otherwise, we don't give antifungals even if they have septic shock. If they don't have risk factors for fungal infections, we don't give antifungals. And then when we give beta-lactams, we give infusions rather than giving a bolus dose. There are reasons. The pharmacokinetic, pharmacodynamic principles should be followed when you give antibiotics. We will describe this a little here, because we have many different antibiotics available to us. Some antibiotics act, especially the aminoglycosides, we have to give daily doses to obtain the maximum peak, because this graph will show the concentration of antibiotic against time after you administer your antibiotic. And if you give a single dose and get a very high peak, so this MIC is the susceptibility of the organism causing infection. So you measure the maximum, the peak and the MIC. If you can see for aminoglycosides, the PK/PD parameter is this. That is why we give aminoglycosides as once daily doses. Earlier, the tendency was to give multiple daily doses, TDS doses they call, TDS, BD. Now the tendency is to give aminoglycosides once daily. But we were talking about beta-lactams. What matters is this dotted line is this MIC of this organism, the minimum inhibitory concentration that is needed to inhibit the growth. So you have to maintain antibiotics at a level above this MIC for a longer period. So we call this a time above MIC. So that is why we give beta-lactams as infusions rather than giving bolus doses. And for some other drugs, it is the area under this curve of antibiotic concentration versus time, and then we divide it by MIC. So those are the PK/PD parameters which we consider. So if it is peak by MIC, it's concentration dependent. If it is the area under curve under MIC, again concentration dependent. So there's no point in giving prolonged infusions for these antibiotics. But if it is a beta-lactam, carbapenems, cephalosporins, penicillins, especially we give different types of penicillins in our treatment, then if it is a penicillin, its activity will depend on the time where we maintain levels of antibiotics above the MIC of the organism. So we give infusions. It's a time-dependent antibiotic. Right. So you have given your antibiotic now. You have diagnosed, screened, diagnosed sepsis, and taken blood cultures, given antibiotics. Now what do we do? The de-escalation. So you have had now your blood culture has become positive, and the laboratory has sent you an ABST also. So you have started a very high spectrum antibiotic, maybe something like imipenem, meropenem, which is a popular thing these days. But your organism that you have isolated in this blood culture, the patient has a very susceptible organism. So you stop that broad spectrum antibiotic, but go for a targeted therapy with the antibiotic for which the organism is susceptible, maybe a cephalosporin. So you go for that antibiotic. That is called de-escalation. And then when you have de-escalated, again, rather than giving a fixed duration of therapy, earlier we said, okay, this many days of antibiotics, 14 days of antibiotics. Now you have to assess the patient daily and de-escalate accordingly rather than giving a fixed duration of antibiotics. And then how many days of antibiotics? What is the course of antibiotic? This surviving sepsis campaign, last year's guideline, they recommend shorter courses of antibiotics over longer durations. So they have assessed many different papers and meta-analysis, and they are agreeing mostly on the shorter durations, maybe 5 to 7 days for a pneumonia, like that, 5 to 7 days for a UTI causing sepsis. So shorter durations are recommended on these patients. And then at this moment, of course, if you are not sure whether to de-escalate or not, you may use procalcitonin along with your clinical evaluation when you are deciding on the duration of treatment. If you are not so sure, you may do that too. And if it is low, you may stop antibiotics there. And then coming to the next important step, source control. So for this, we know the sepsis, there was a source definitely. So we have to look for this source. We have to look hard for that to identify the source. And then we have to exclude a specific anatomical diagnosis if possible. And if you have identified the source, emergent source control, this is very important in surgical practice. So if it is a patient with peritonitis, if it is a bowel perforation, you do the source control immediately. If it is a patient with necrotizing fasciitis, there's no point in waiting for the infection to settle with antibiotics. You will have to go for fasciotomy in that patient. Like that, emergent source control, if it is an abscess, you have to drain pus. And all those source control mechanisms are very important in the management of sepsis. So intervention should be made as soon as it is medically and logistically practical. Your patient should be stable enough to go to theater, and then arrange theater and do the source control. If it is a patient with an intravascular access device, a central line, if there is a central line, again, you will have to you think of central line infection, removal of the source is the best for the management of sepsis. So for the diagnosis of central line infections, we wanted to take 2 blood cultures, and with that, if we confirm that central line is the source of this sepsis, removal of the central line is the source control that is recommended. Coming to the last slide, we have done all those things. Now we have remove the source also, given antibiotics. But beyond all these things, there is one thing that you have to do, that is prevention. Prevention of sepsis is the best thing. So some of you may have attended this Sepsis Day 13th of September programs, World Sepsis Day. There were many programs organized by different bodies. So you can contribute in prevention of sepsis. You can promote vaccination among people, and you can promote the use of clean water. Of course, you can't give access to water, but then you have to think of hand hygiene. This is something that you will hear over and over again when you start appointments. Hand hygiene is very important because that's the single most important step in preventing infections inside the hospital. You may wash hands with soap and water or use the hand sanitizer, alcohol hand rub. During the last 2 years, people were talking about hand hygiene. In the hospitals, we have hand hygiene improvement programs. There will be audits on hand hygiene. So that is a very important thing for the prevention of infections, because especially the hospital-acquired infections. So healthcare-associated infections, there is a difference between hospital-acquired, because in hospital-acquired, we attribute it to the hospital where the patient was treated. But in healthcare-associated, maybe it is a device that is inserted, but the patient is going from hospital to hospital. You can't attribute it to any particular hospital, and but it is definitely associated with some healthcare. So that is a broader term, healthcare-associated infection. So who is responsible for these infections? Definitely the healthcare providers. Healthcare providers will be you when you start internship. From that to the whole unit, the whole hospital, we are responsible for preventing healthcare associated infections. So you will be taught about this later on. So prevention is very important, because in hospitals we spend a lot of money for antibiotics, mainly for patients who are developing healthcare associated infections. We know these infections are resistant to many different antibiotics. You would have seen as students the reports coming as multi-drug resistant organisms, where you give multiple antibiotics, which are very expensive. So prevention is the best tool here. And in the community also, the prevention programs will help. That is as the best strategy to prevent sepsis. And that brings us to the end of the presentation. Any questions? I think we have about a few minutes for questions. Are they allowed to ask questions?
Yes, madam.
I think I have not handled the resuscitation, the ventilation, all those things here, because we are focusing mainly on the management of infections in these patients. There's a lot more to discuss in sepsis. Our one bundle has to be discussed at length, which type of fluids to give and all those things, and how to achieve how to monitor the targets and all those things. I'm sure they would have been discussed or will be discussed by the other colleges. So I have not handled that part. And then the ventilation strategies and all those things, other therapies will be mainly for the patient managed in ICU. So I did not focus on that as well. Right. I'm sure this is all final year stuff that you have learned. But please remember all these things. When you come, you will be able to save lives as the first level care provider. You will be the key person to detect sepsis early, as well as to prevent sepsis, to talk to people, to educate people. There's a very big role as a junior doctor. So we expect everyone to understand that role, remember that, and to fulfill your duties to the maximum to prevent sepsis and to save lives in future. There are no questions. Can we wind up? Thank you for your patience and wish you all the best to manage sepsis during your future career. There will be more and more guidelines coming. It's been revised very frequently. So keep yourselves updated on the new guidelines and try to manage sepsis. Thank you.
Right. Thank you very much, madam. That was Dhammika Vidhanagabage, consultant microbiologist at large. Right. So we'll go for lunch break. So 12:15 to 1:15, we have a lunch break. So join at 1:15. Thank you.
Okay, thank you.
Okay, welcome back after lunch break. So next lecture is by Dr. Madhuvani Bewardhana, consultant clinical microbiologist at National Hospital, Kandy. Collection and transport of microbiological specimens. Over to you, madam.
Thank you. Good afternoon to you all. You are welcome to the clinical field. We are going to discuss about collection and transport of microbiological specimen. So you have discussed many important points in the morning. So we are directly going to the lab now. So the objectives of my presentation is to discuss the principles of collection and transport of specimen of common microbiological tests. With additional practice, you'll be able to collect proper specimens, arrange for proper transport, and interpret common microbiological tests at the end of this presentation. So why this is important? It's a quality of the specimen depends on the quality of the report. If you put garbage, you will get garbage out. So quality of the specimen is very important to do a quality test as well as to get a quality report which can be used to treat patients. So actually any test has a cycle. The first part is pre-analytical, that is from the ward, and analytical, which is done in the lab, and post-analytical with the final report. If anything goes wrong, sampling, labeling, transport, storage, and patient's information, it will affect the analytical part, such as microscopic evaluation, microscopy, culture, identification, interpretation, and antiparogram. You will understand during the lecture how it happens. So when these two goes wrong, the rubbish report will be available. So to have a useful report, you will have to have all the parts of the cycle correctly done. So before collecting samples, we have to know, is there an infection? That is very important, because just collecting samples, wastage of time, money, and everything. And if there's infection, where is the infection? Is it chest? Is it urinary tract? Or is it wound? Is it bloodstream? And what are the appropriate specimens? These are very important before collecting samples. Getting so many samples is, it's useless. So I will give you one case. 62 years old patient with fever and chills and backache and dysuria comes to the ward, and samples taken were full blood count, UFR, blood culture. Is that all? I think you can't answer in this setting, but just think. So in a patient like this, this is very common things which happen in. Well done. Thank you. Yes. So this is something missed by so many senior people than you. So what we need is a urine culture. This is missed, unfortunately, that I'm so happy that so young, fresh people like you understands more than the older people in wards. Because when you go to the ward, urosepsis is a diagnosis, but there's no urine culture done. And another example, patient with diagnosed dengue, day 1 in ICU. Samples taken, blood culture, urine culture, ET secretion culture. Are they needed? What do you think? Diagnosed day 1 in ICU. Diagnosed. Do you think it's needed? We don't think. Unless it's secondary infection, we are wasting our resources. Full blood count for the previous one. Okay, yes, thank you. Likewise, we have to make sure that we want particular sample rather than doing kind of routine thing like doing everything for blood count, UFR for each and every patient. It's actually useless. So which sample to be taken? Depend on the presumptive diagnosis. Example, urosepsis, we need to take blood culture and urine culture. And if skin and soft tissue infection, pus, aspirate, or at least a wound sore. If it is pneumonia, to have sputum. And when you consider about samples, pus is a better sample than a wound sore. We are going to discuss why and all in next few slides. And stool is better than a rectal swab. Stool cultures are done. And lung aspirate, pleural aspirate are better than sputum, obviously, but the availability and possibility of doing lung aspirates and pleural aspirates are not common. So expectorated good sputum sample will be adequate when needed. So blood culture is a useful in systemic infection. If there's no fever in a otherwise not immunocompromised patient, you don't have to take blood cultures each and every person who comes to the hospital. In a localized infection, samples should be collected from the site of infection, such as wounds. When the site is not visible, so patient comes in septic shock, you can't think whether it is meningitis, whether it is bacteremia due to urosepsis, whether it is GI infection. So then, of course, you'll have to get the cultures as much as possible to detect the organism. If possible, if there is little signs of at least the meningitis, to take a CSF sample, blood culture definitely, and urine to exclude UTI and sputum if possible, and so on. It is, apart from septic patients, it's useful in neonates and ICU patients and patients with pyrexia of unknown origin. So some samples depend on the stage of the illness and microbiological facilities as well. Again, we are talking about it in next slides. And when? Always try to take the microbiological samples before starting antibiotics. Before the first dose of antibiotic would be the best. But if the patient comes from the community after getting treatment from so many GPs and all, so yeah, what to do? But still, at ETU, if the patient is septic, it's better to take the sample when you insert the cannula. Earlier the better, and repeat sample if necessary, such as in conditions like with intermittent presence of pathogens, like in TB, to take several samples of sputum, early morning samples, 3 in consecutive days, and so on. And serology need to be timed for the antigen or antibody, because we know that if it is dengue, you have to take, if you take during the first few days, first 5 days, 1 to 5 days, 5th day, you have to test for antigen. And if after 5th day, you have to do the antibodies, not vice versa, because it's not useful at all then. Or you can, if you have the combo test, depending on the situation, you can still request antigen or antibody, depending on the fever duration. An appropriate specimen, as I said several times before, collected before antibiotics, from the site of infection, avoiding contamination, because what we get, many blood cultures with coagulase negative stuff, and most of the time they are contaminated. So it's useless for the treatment, and it's waste of money from the lab side and the time as well of the technical person. And a proper sample and sufficient quantity. Where you need 1 ml, a drop will not do, because CSF, most of the time what we get is few drops, which cannot be centrifuged to do the proper culture. And correct methodology, we are going to discuss an optimal time and a proper container and transported correctly as well. All are important. During the collection and transport, as I said, minimize the contamination and please follow standard precautions. I hope you all know about standard precautions, which should be taken by healthcare workers, all the healthcare workers, all the time when you attend all the patients. No, you don't have to know the patient, whether the patient is having HIV or not, because it is unethical to know whether the patients are with HIV or not. You have to consider anyone is positive with HIV, hepatitis B, hepatitis C, and so on. And you have to take precautions according to the sample or procedure you are going to do, such as wearing all the personal protective equipment to do all the procedures as useless, and it's incorrect, and it's kind of, actually it's stupid. So standard precautions are like, if you are going to touch body fluid, you'll have to have gloves. And if you are going to take a respiratory samples, apart from gloves, you'll have to have a mask and a face shield, because otherwise patient might cough on your face. And if you're kind of like splashes, you are expecting splashes, you'll have to have better to have a sorry, apron, plastic apron or something. But just imagine to take a urine sample, if you are wearing masks, face shields and aprons and everything, it shows that you don't know anything. So better to know and show that you know by doing the correcting correctly. And please prevent accidental injuries. Know when you collect blood for some investigations, do not do risky procedures where you can get prick injuries. Don't cap the needle and so on. There are so many precautions you have to take, and so avoid, and by any chance, if you get accidental injuries, always report the injury and get the required management according to the plan. And try to maintain the sample in original state. So it should be kept in a sterile container until it is sent to the lab. Because I would say most of the microbiological samples should be sent in a sterile container. But why I said most, because stool cultures you can send in a clean container, which hasn't to be sterile, because what we are looking for is different. But in other samples, you'll have to take the samples into a sterile containers. Ideally is screw capped, or depending on the sample you take. And what are the investigations we do in microbiology? Mainly bacterial studies. Apart from that, mycobacterial TB studies, fungal studies, viral studies, serology, and molecular diagnostics. So all are done in microbiology, but in most of the hospitals we do bacterial studies. So in a microbiology laboratory, what are the tests we do? Blood cultures, CFSF gram stain and culture, sterile fluid gram stain and culture, urine cultures, sputum, tracheal aspirates, gram stain and cultures, pus or swabs, gram stain and cultures, high vaginal swabs, endocervical swabs, or sometimes urethral swabs, fungal, scraping, direct smear, and probably cultures, MRSA screening, stool cultures for Shigella and Salmonella. That's what we, in an average microbiology lab, we do all these investigations. And we are moving to blood cultures. So the specimen could be from a peripheral vein by venipuncture, from a vascular line, example, central venous pressure line, or bone marrow biopsy. So, blood culture collections, you have to know, and it's to be done by a medical officer. It's a medical officer's job. Prior to take the sample, you have to wash your hands with soap and water and clean with alcohol around the selected site and allow to dry. So you have to select a place to collect the blood wherever feasible, and depending on the age of the patient's current status and everything. So initially you have to clean with alcohol and leave it to dry, because action will be there after giving it few seconds only, because you can't just rush swabbing with this alcohol and then swabbing with povidone iodine and take the sample. Then the contamination risk will be very high. So initially alcohol and then with 10% povidone iodine in a concentric fashion. I mean, there are different opinion about cleaning, but this is what usually we do from center to the periphery, and allow at least 2 to 3 minutes to act. So starting from the beginning, after cleaning, you have to wait about 3 minutes. This action will be there then only. Or you can use tincture of iodine, and what we have is alcohol and povidone iodine. And then you have to wear, if you have been wearing gloves, you have to remove it and change it. Just a pair of disposable or sterile gloves. You don't need to have sterile gloves always, because you're not going to touch the place which you have cleaned previously. So this is a PPE for your protection, because you are going to bleed the patient and you can get your hands contaminated with the blood. That's why you are going to wear the gloves. It doesn't or palpate the area after cleansing. Collect 5 to 10 ml of blood from adult or 1 to 3 ml from children. And clean the top of the blood culture bottle. I will show some blood culture bottles pictures on the next slides. And clean the top after taking the flip, and clean with 70% alcohol and add the blood into the bottle aseptically. And if it is conventional bottle, in some hospitals still we are having the conventional bottles, you have to close the bottle tightly and mix well. And whatever the bottle, you have to mix by rotating, not like shaking. You have to rotate and mix so that blood is not clotted. And you have to send it to the lab immediately, because this is a very important sample. You have to know the organisms. But if the lab is closed after 4, keep at the room temperature, not in the fridge, not at all, never in the fridge. You'll have to keep it in the room temperature, because we want to allow the organisms in the blood to grow. If you keep in the fridge, organism will either die or they will stop growing. So you have to give them a proper warmth, ideally 35 to 37 in the lab incubator, but at least in your room temperature, which will not, if not enhance, but it will not suppress the growth. So blood collection, frequency of collection, we'll discuss in the next slide. It depends on the bacteremia, whether transient or intermediate, and number of cultures you have to decide. And usually, I'm going to talk about it in next slide. So blood culture bottles, as I said, we have automated blood culture bottles, different types. So we have this Bactec bottle and Bactec Alert bottle. Either both bottles are good. And our conventional methods, where we use some sterilized bottles, glass bottles with screw caps, which is not as good as the automated blood cultures, but due to unavailability of automated blood cultures and the machines in all the hospitals, still in some places they practice conventional blood culture method. And central line blood cultures. Remove and discard the clave connectors, because you have to remove the cleft connector, and clean the hub with alcohol for 15 seconds, which is not being done in many places. What they do, remove the cap and just give a single swabbing with alcohol and take the sample. So whatever the organism in the hub are remaining. So what you need to do, you have to clean the hub with alcohol for 15 seconds and followed by tincture of iodine as well. And then discard 5 ml, 3 ml if pediatrics to clear the line. Because if you take blood culture straight away from the clean, disinfected hub, the organism will be killed. So that you'll have to draw some 5 ml of blood and discard it. And then, of course, you'll have to collect the proper sample, either 5 to 10 ml of blood, depending on if it is an adult, or 3 ml from pediatric patients. And then you have to remove the iodine with alcohol from the hub with a swab and flush SOS and place a new cleft connector on the hub. This is hardly being done in any place, and you can observe and see whether it is being done in your hospitals. This is the reason for blood culture associated infections as well as contaminations of blood culture. Are you getting really disturbed? Because this is a lunchtime, our lab is very noisy. Are you getting really disturbed, or is it all right? I can ask them to keep a little quiet if it is disturbing, otherwise we will go on if it's not a big bother. Is it all right? All right, thank you very much. Right, okay. Right, so these are the frequently asked questions. How many blood cultures to be taken and when? The slide is busy, but this is what you always ask us. So it depends on the condition and unfortunately country situation as well. Why I mean by country situation, because where we have to take, say, to take 2 blood cultures, we have to say, well, I mean, you can't take 2 blood cultures all the time because we don't have enough resources. Right. Always before starting antibiotic, we have discussed it again and again. And in sepsis, it's better to take 2 cultures. When you insert the cannula, you can take one from that side, and from a different side, you have to take the second one. Because always don't take some blood and divide it into 2 bottles and send to us, because it's useless. Because we have to catch the bacteremia. So for which at least 2 different sites at the same time. So PUO, better to take at least 2 samples from different sites, at least half an hour apart, because intermittent bacteremia will have to catch by taking in different sites in different times. In fever, high fever, better to 2, but at least 1. And the other thing is, don't wait for fever spikes, because we never know when the patient gets fever. And the other thing is, fever means body reaction. So the organism will be killed at the spike of the fever. So take any time before antibiotics. If the patient is already on antibiotics, and if you cannot withhold antibiotics, just before the next dose. So if the patient has been on antibiotic when the patient was transferred to your institution, so just before the next dose, you can take a blood culture. Because then, of course, the concentration of blood is minimum, and there is a chance of getting some organisms if the bacteremia is still there at that time. For endocarditis, minimum 3. First and last to be taken at least 2 hours apart to fit into our guide, the criteria to diagnose endocarditis. And of course, we get lots of contaminants in blood cultures. So collection is very important, as we discussed in the earlier slide. It has come halfway. Anyway, CSF cultures. So aseptic conditions, skin disinfectant, 70% alcohol, and povidone iodine as for blood cultures. Adequate volume. How much do you think we need CSF for cultures? Can one use the chat box? How much for bacterial cultures? How much do you request for? Any idea? You are scared to guess, is it? Okay, there's one answer. Bottles, yeah, because for microbiology we need one. And how much do you think that we need a volume? Well done. Well done. Okay, yes, thank you. One said, Dr. Abekun said 3 to 4 ml. And I don't get the name fully. Someone has said at least 2 ml. Yes, please. When you go to the wards, try to take at least 2 ml. Actually, it's better if you can 5 ml, but what we get is 2-3 drops at the bottom of the bottle, which we can't centrifuge or do anything. I mean, do you expect in a single drop to have organisms unless it's kind of like pus-like CS? So most of the time there are some bacteria in the CSF, but because it's not a lot, you'll have to centrifuge it and get the deposit and do the investigation. So just a drop is always gives almost always give negative results. But if you can get at least 1 ml, which we can centrifuge, we can give a proper report. And of course, sterile screw cap bottle and transfer immediately. Mention the time of collection as well, because the organism in the CSF, can you remember the organism in the CSF, meningitis patients? Because this is very important. What are the organism? At least one, if you can type on the chat box. What are the organisms you expect? Okay, TB, in TB, mycobacterium, yes. And in common meningitis, other bacterial meningitis, what are the organisms you expect? For mycobacterium, of course, you need 3 ml at least. What are the other organisms? You are freshly from your faculties, so you need to remember the organisms as well. Neisseria meningitis, okay. Any more? Because this is the least one. We hardly get Neisseria cultured. I don't know why. Anything else? Maybe one reason is here as well. Can I wait for another answer? Streptococcus pneumoniae. Well done. Thank you. And Haemophilus in neonates, smaller children, and coliforms in neonates like E. coli, and group B in neonates, and so on. Yes. And actually, these organisms, although they can kill us, they are most of the time they are very fragile. They die. If you delay the sample, the organism will get killed. So you have to send it without delay at room temperature again. Never refrigerate bacterial samples, not in ice, not in refrigeration, because it will kill them and we won't have the organisms unless you want to do some antigen detection or molecular studies. Then of course refrigerate the second sample. For microbiology, if you want to grow them, you have to send as soon as possible to the lab in room temperature. And we are moving to urine culture, another very important, because this is the most common sample we receive in microbiology lab. You have to get it in a sterile bottle. You have to get a clean catch urine sample, a midstream, after cleaning the area around the vagina or penis, cleaning. So here there are going on several discussion on this in our country as well as in And I mean, it's in our country at the moment, but in other so-called developed countries, they say not to clean with soap and water, or even just water, because it can make the possibility of getting contamination and the destruction of organisms higher. So, okay, better to have a clean catch. We are trying to put this into our future guidelines, especially in as long as I know that the University of Peradeniya, they were discussing very much about this problem, whether they are following UK guidelines where they say you don't have to clean with soap and water or with just water and dry yourself, because it will make the things worse. Rather, it's better to get a clean catch midstream sample without cleaning, because it will flush the organisms in the superficial area. And if you catch a midstream one, that is the best sample. So there is kind of, but definitely not with soap, because it will kill the organism. So it's in a discussion in our country. And send to the lab without delay, and if delayed, refrigerate. This is the most important sample which has to be refrigerated before sending, if it is getting delayed. Do you know why? Can one guess why? Why here? Why do we want a refrigerated or in ice sample if it gets delayed? What is the reason? Can anyone can give your idea? See, just whatever comes to your mind. So you can give your opinion on the chat box, and we are moving to the next slide. So in a patient who's being catheterized, so I've got one answer. Avoid lysis of organisms. Right. Okay. That is one reason. Okay. Right. Organisms commonly encountered with UTI are heat. Right. Okay. Innovative thinking. Heat sensitive. Reduce growth. Colony count is important. Right. So this is closer to the truth. To reduce the growth, colony count is important. To reduce the growth, yes. I mean, there's no full stop, and full stop punctuations, actually, it's important, because so to take it as two sentences, to reduce the growth, yes. Not to reduce the growth, to keep the growth as it is, not reduce. And definitely colony count is very important, and that is EPL Pereira, I think. Very good. That is the reason, because this is the only sample. You can't say exactly on the sample. Not there are some other incidences as well, but we count the colonies. How many colonies per ml? Then only we decide whether it is significant or not. So we want the exact growth of organisms at the time of collection to be there when we streak on the culture plates. So I have plate picture there in the next slide, but now we are talking about catheterized samples. When you take a sample, this goes to the pictures, credit goes to my previous RHO, Dr. Samita. Now she's not anymore RHO, she's a MO microbiology in Badul at the moment, who took these very valuable pictures. You have to clamp the catheter before above the bifurcation, right? As in the picture, I don't see because this my okay. Yeah. So here you have to clean the catheter here with alcohol as though for blood cultures, and use the sterile needle and a syringe, aspirate 5 to 10 ml, and can you see the direction of the needle? From up to down, not otherwise, not from down to up, because it might make leakage. So you have to keep you have to pierce this way from top to bottom, and take 5 to 10 ml, release the clamp, and withdraw the needle. So this is one the way of collecting catheterized sample, and as you know that you can collect suprapubic aspirates as well. And this is the culture plate where you streak the way, like you go like this and you streak like this, and you count the colonies in a pure growth. If it is mixed, you don't count them. Here you can see different colors of colonies. Here we take it as a mixed growth, but in this one we see although it's difficult to count the colony count because it's more than 100. If you start counting, you can count, but I don't have a good picture here. You have to count, and there, if it is above 100, we say it's about 10 to the power 5, and if it is between 10 to 100, we say between 10 to the power 4 to 5. And then you interpret. This is a semi-quantitative method. Why I say semi-quantitative? We interpret it because we don't use 1 ml of urine culture, but interpret 1 microliter streaking here, and we interpret it into a as though it's per ml. So when we get a good count, we say significant growth of colony counts isolated, and we do the send the sample. And moving to the next sample, we have a lot of things. Wound samples. It could be tissues, punch biopsies, needle aspirates, swabs, and scrapings. And tissues, punch biopsies, and needle aspirates are the best samples. So pus cultures, pus aspirations, either pus swabs, 2 ideally, but I don't recommend at the moment because again we are with limited resources. We need 1 at least. And so when you send the sample, we do gram smear, and in a very good sample, we see pus cells like this and some epithelial cells as well. So wound swabs, all wounds are contaminated, so positive culture does not automatically indicate any infection. If you take a sample from this wound, it will grow so many organisms because it's not, there are pus, there is pus, but you don't do a culture from this wound. You have to clean it initially, because if you take a swab without cleaning, it will have so many coliforms, pseudomonas, etc., and everything. But that does not mean you need to treat. And look at this chronic wound. If you take a sample from here, again it will grow something. But do you think it's infected? It's not. You don't have to treat all the wound swab cultures, and you have to select what's wound you need to culture for, take samples for culture. So you have to determine clinical based on the wound characteristics, whether there is erythema. Here you can see some erythema, edema, pain, heat, increase exudate, and odor. So otherwise, it's waste of time, waste of money, and you will get confused when some very resistant organism comes in your wound swab in a very healthy, otherwise no fever patient, and you think whether we need to treat with meropenem or something for this patient or not. So proper technique for obtaining a specimen is crucial to avoid false negative or false positive results. So we have correction methods, Levine method. And then wound swab culture collection procedure. So you have to, initially you have to wash hands, apply gloves, remove soil dressing, and place in a biohazard bag. You have to, initially you have to wash your hands and apply gloves. Whatever dirty the wound, you have to wash your hands and apply gloves for your protection, and remove soil dressing and place in a biohazard bag. And so you are removing the wound, and clean the wound by removing excess debris from the wound base by irrigating with normal saline. Thoroughly flush the wound very well. And then gently wipe the excess with sterile gauze pad, and moisten the culture swab with a normal saline, sterile normal saline. Because it otherwise after cleaning and drying your wounds, sometimes you will not get some organism into your swab. Identify a small area, 1 centimeter of clean visible tissue, and rotate the swab on it for 5 seconds. So I have a method on the next slide. Of clean viable tissue and rotate for 5 seconds while applying enough pressure, because avoid necrotic tissues and wound edges, because wound culture must be taken from a clean tissue, not that as though in the previous wound, you should not take the sample from here. You have to clean, and not from the edges, but from the middle of the wound. And you take the sample and insert into the container and re-rest the wound and send the sample. So why I'm telling about the cleaning the wound before taking the sample? Because if you don't clean and take the sample from the the pus containing wound, the culture will grow like this. So many organisms where you can't read anything. But if you take the proper sample, you get a nice growth of Staph aureus, or whatever here it is, Staph aureus, in a plate, and you can do the sensitivities for these organisms, and you will get a very good result on the next day. Swabbing method, there are 2. Either you can swab in this way, zigzag method, or the Levine method by rotating in like a single centimeter like this. You can rotate and take. Tissues are better samples, but should be in a good quality. Avoid drying during the transport and send to the sample. Any pus and tissue sample should come in sterile, wide-mouth, screw-capped containers, and aspirated pus obtained during the surgery is precious specimens, and make sure it is being sent to the lab, because most of the time when the ward calls us to get the report, and then only they realize it is still in the theater. So you have to make sure it is being sent. Tissues, infected viable tissues after removing non-viable surface tissues, because just slough don't send, because it's just so many organisms colonized and biofilms and all. And moving to the sputum culture. Send expectorated sputum, not saliva, because if you say to the patient, bring some chelatic again, it will not work. You have to explain the patient, cough properly, and you can help with some kind of nebulization. The proper expectorated sputum, and semen, it's not chela. And when you send it, we do the direct smear. And if we see epithelial cells, it is salivary, and we say it is not a good sample, and we are not proceeding anymore because it's salivary sample. Your saliva contains so many organisms. There's no point of doing sensitivities or culturing of these things. But if that a good sample like this, where you see pus cells, neutrophils, and organisms, can you see the diplococci? So it's a good sample, and we will proceed and do a culture and send you the proper samples. If the patient is ventilated, common sample is endotracheal aspirates or bronchoalveolar lavage if possible, for which you need a trained chest physician or someone, or induced sputum is taken after nebulization with hypertonic, and so on. And another sample from upper respiratory tract, it is throat swab. So you know how to take a sample, tongue depressor and good lights, sterile cotton swab, rub both tonsils and post-pharyngeal wall, quickly send to the lab and send the sometimes in transport media. So bacteria cultures, actually what we want to, and what we are looking for is Streptococcus purulens, which grows on the blood agar plate like this, with giving hemolysis. And of course, for viruses, the swab should be sent in a viral transport media. And nasopharyngeal aspirates, mucus extract like this is helpful. You have to send to the virology lab in a transport medium. And rarely for Neisseria and Haemophilus, you have to send it in a room temperature. Pernasal and nasal are different. Pernasal swabs again for viral studies. You have to collect, as in the picture, you have to collect it correctly, not from the nose, but nasopharyngeal area. And if it is anterior nasal swab, so MRSA or Staph aureus, which is being done for just before some cardiac surgeries, orthopedic surgeries, and so on. And they are done for healthcare workers or food handlers and so on. You have to take a nasal swab. Not like this, but just a nasal swab. And ear swab, aspirates are better, sterile swabs. And what is very important, you have to clean with saline soap swab before taking the sample, because there will be collected pus here. You will have to initially remove it and then take a sample, because here again, there will be skin colonizers and everything here, and coliforms and so on, that we won't get the pathogen. But initially you clean with normal saline and then take a sample. It will show sometimes the pathogens. And sinus debris in fungal sinusitis and all. You need fungal cultures, better accompanied by a biopsy, and transport to the lab as soon as possible. If you want bacterial cultures, years, and otherwise fungal cultures and fungal smear. And in eye, sterile swabs, corneal scraping, corneal buttons, and vitreous and aqueous aspirate from endophthalmitis. So can do bacterial and fungal cultures. Again, not just collected pus, try to take from the conjunctiva. Urethra specimen, patient should not pass urine before 2 hours with collection. Clean meatus with sterile saline, sterile swab. Do post-slide bedside inoculation is the best for if you are looking for gonococci. Samples for chlamydia should be sent in transport media. Actually, these are not done in routine microbiology labs. It's done in the either STD clinics or in if you looking for chlamydia, it's in MRI. So endocervical swabs and high vaginal swabs, they are different things. So you have to take it in endocervical swab, moisten the speculum with normal saline and insert. Avoid antiseptics. Don't use any antiseptic before taking the sample. Sample should be from the should come from the endocervix, not from the vaginal wall. Gently rotate the swab and when the in cervical canal. And HPS take from the posterior fornix. And what are you looking for? Normal flora with epithelial cells, which will look like this, epithelial cells and lactobacilli, and Candida species, like this in candidiasis, or clue cells in bacterial vaginosis. And Trichomonas vaginalis swab should be sent in normal saline, because if it get dried, you can't see anything. So you have to send it very quickly and do the microscopy, direct microscopy so quickly. And so they have to inform the lab before sending. And in fungal scraping, nail scraping and all, you have to collect it to a black drawing paper to it to be visible. So you don't need transport media or anything. You can just send to the lab. And the other studies are like cryptococcal antigen, Aspergillus antibodies, and galactomannan test done in the serum. Anaerobic cultures are done at MRI, transport media, Robertson cooked medium broth. So it is only available in MRI. If you need, you have to contact the lab MRI and make the arrangements. And PCR done for, especially now we all know about this because of the COVID. Clean sterile bottle with DNases. Without DNases, sorry, sample depend on the condition, and we can send for either, the gene expert, that is for TB PCR. So we have different PCR for different organisms. You have to make sure that it is being done and where it is being done, and send the sample to the particular lab. And antibiotic levels, hardly done, but very important. You have to discuss with the lab, and you have to send the sample at the peak or trough to check vancomycin and gentamicin levels. And so request forms, you have to fill properly. You have to give the name, age, what you want, and what is the probable diagnosis, and what is the clinical condition, because it is important to proceed. take-home message, is there an infection? You want microbiology test, what is the test, how to take, and how to interpret. So we are going to interpret quickly a few reports. This is from real situations. So this is peripheral line, no growth after 24 hours of incubation. So normally we incubate blood cultures for 24 hours. As you know, microbiological investigations take time. They are not, they cannot be done quickly other than the direct smear, which can be done instantly, but all the other, because bacteria take time to grow. So we issue the first negative report after 24 hours or positive report, depending on the culture. So another one, so these are the what we do in the lab. We just make small notes so that this is a urine culture where we have seen coliforms 10 to the power 4 to 5, and we have done the sensitivities and we are sending it to the lab. So this is one pus culture where we have isolated MRSA. So if it is MRSA, that means it is resistant to cloxacillin, as well as it will be resistant to cefalexin, all the cephalosporins actually, cefiroxim, and you have, and amoxiclav as well. This is something, because even though it's not written, you have to know that MRSA are resistant to all the cephalosporins, even meropenem, imipenem, if it is MRSA. So you have different antibiotics depending on the sensitivity to treat the patient, such as if it is sensitive to clindamycin, you can use clindamycin. If it is sensitive to ciprofloxacin, you can use ciprofloxacin. If it is sensitive to cotrim, you can use cotrimoxazole. But it's uniformly resistant to, even it is not written, it is resistant to these all the cephalosporins and meropenem and imipenem. So this is another one, urine culture coliform, ESBL, about 10 to the power 5 coliform units. And the report comes like this. So again, if it is ESBL confirmed, it's always resistant to available cephalosporin in Sri Lanka. So you cannot use any of the cephalosporins, but if it is sensitive to cipro, you can treat with ciprofloxacin, and it is usually sensitive to meropenem. There's no other resistant mechanism detected, or depending on the sensitivity given in the laboratory report. And this is a coagulase negative staph isolated after 2 hours of incubation. Most of the time they are contaminant, unless the patient with a central line where there is a chance of being a pathogen as well. And again, another ESBL with the sensitivities. And sometimes in pus culture, we may have 2 types of organisms, but these can be even colonizers. So to 1 note 1 and 2, we give the sensitivity for 2 different organisms in the given chart. And this is a MIC report. Sometimes you will get when there is the availability of Vitek. This is a blood culture, Klebsiella pneumoniae, where we get the proper name and sensitivity as well. So here it gives minimum inhibitory concentration as well as the interpretation. So it says MIC is above 32, so it is resistant. So if it is less than 1, it is sensitive. Here it's meropenem less than 0.25, it is sensitive, so on. And it's always comes with the interpretation, because you can't remember the MIC levels. If you get the MIC level, if you get MIC levels in your reports, you have to contact the lab and ask for interpretation from the laboratory. This is dengue IgM, IgG antibody test. So here, dengue IgM antibody is negative, dengue IgG antibody is negative. So negative results, here we have given interpretation. Negative results do not exclude dengue virus infection, suggest repeating test after 5 to 7 days. Usually, if it is dengue, sometimes it will be positive, either one will be positive, but it depends, as you know, the timing of the collection of the sample. If it was like not enough to develop dengue antibodies or something, it sometimes you will get a false negative as well. And the other thing is, of course, nothing is 100%. As you know, any test will have a negative, a false positive rate as false negative rate, where you have to consider the positive predictive value and negative predictive value, because nothing is 100%. So that you have to evaluate it clinically. So here, COVID antigen test, which says negative, again, negative report of a suspected asymptomatic symptomatic patient should be confirmed, and so on. And rapid COVID antigen positive one. So, so that we can have, this is another PCR report of some patients. And again, COVID test results, how we interpret, because so with the incubation, we will not have anything positive, but PCR can get positive at very early, and so at later, PCR still can remain positive for a time period, but antigen become quickly negative. Another reports, and we are concluding. So microbiology lab usually works 8 to 4 p.m. It's no night lab available at the moment in Sri Lanka. So normally we receive samples, say not 2:30, but 3:15 sometimes. Why? Because we have to get the media ready for the testing. So any question regarding sample collection, you can contact your microbiology laboratory or your consultant microbiologist in your hospitals. If there's any questions, we have 5 minutes. I think we have covered everything. If there's any question, you can type on the chat box. So I hope that you will be mindful on doing some testing, not just routinely doing everything, but choosing what you want and use it mindfully as well. Not treating all the cultures, as well as not ignoring important cultures. Not treating all the cultures means you should not treat all the bone swab cultures, OET, secretion cultures, if they come unless a patient is clinically unwell. But if you get in a blood culture some pathogen, don't ignore as well, because both things happen in some units. And so that, just imagine that you get urine culture positive in a patient with pyelonephritis with the sensitivity of only to meropenem. So you can't say that the patient is well after 3-4 days and discharge the patient. Because pyelonephritis you have to treat for 14 days. So likewise, use wisely all the reports.
Right. Thank you very much, madam, for that detailed lecture on microbial specimens. So if you all have questions, you can ask madam now. At the meantime, next lecture is prevention of hospital-acquired infection by Dr. Geethika Pathapadige, consultant microbiologist at National Hospital Colombo and the president of College of Microbiology.
Yes,
So,
Roshan, I am there.
okay, madam. You can
Thank you for
start.
the introduction. Yeah, you have to share the screen, I think. Roshan, can you hear me?
Yes, madam.
Roshan?
Can yes,
I
can
don't
hear.
know, there is a problem with screen sharing. Shall I try again?
No, you are using a phone or a computer.
I am using the phone.
I'm sorry.
I am using the phone.
Phone. Okay.
Phone, yes.
Okay. So I think there won't be a problem.
So I will share now. I'll try. If not,
Okay.
I will email it to you quickly.
Okay.
Yeah.
Yeah. We can see, madam. Yeah. Right.
Okay. Yes. So shall I start now?
Yes, madam, please.
Yeah. Good afternoon, all. Can you hear me?
Yes, madam. Can see.
Yeah. Okay. Good afternoon, all. The topic I was given is prevention of healthcare associated infections. So, as you know, the hospital is like this. A lot of interventions are happening. Antibiotics are being used, though it has to be rational use of antibiotics, but we see sometimes irrational things also happen. We try to minimize them. And as you know, there is a big fight between bacteria and versus antibiotics due to antimicrobial resistance. So this is our antibiotics are drying up. There is dried antibiotic pipeline. So in the near future, most of the time there won't be any antibiotic under production. So we have to preserve what is available. So it is our duty as medical people, you all are pre-interns. So you all are going to start your internship, and it is your duty as medical professionals to keep what is existing. So there are weeks in November, antibiotic awareness week, November every year, to highlight this issue. So it is an advocacy week. So it is our duty, we keep that in mind and we make the people aware about too. So what we need to do, in addition to rational use of antibiotics, which was discussed in the morning, due to MDR organisms and big problem of gravity of antibiotic resistance, we need to stop spread of the antibiotic resistant organism. That is by that is prevention. So we focus mainly on prevention. Prevention is better than cure, all of us know. So as a single person, I might not be able to do. As a single person, you may not be able to do. But when it is a team of different categories of staff, so we respect each other, so we are able to do most of the things. Likewise, prevention is also possible if we work as a team, which is a need. So team together, everyone achieves more. So as you all are beginners, you have to keep in mind, we do teamwork. So that is for the prevention as well. I just included this slide because as the beginners, you need to know that there is a national strategic plan. From 2017 to 2022, it will be extended. This is on combating antimicrobial resistance in Sri Lanka. In that, there are 5 strategies. Out of them, 3rd strategy is based on prevention. That is, the reduce the incidence of infection through effective sanitation, hygiene, and infection prevention measures. So though you are beginners, you have a long way to go. So you have to keep in mind there is a national strategic plan. We have to consider safety of people. Who are these people? The patient is the focus. Without patients, we will not be having any job to do. So the most important person is the patient. Followed by, we are also important. We are staff members. So protection of staff is also important. Patient is important. And the visitors as well. We should not forget visitors. So safety of all ultimate. Prevention, as I said, prevention is better than costly cure. So the treatment is costly. The prevention is better than costly cure. Prevention, we may need initially capital expenditure. Once it is done, the prevention is cheaper compared to costly cure. So you should try and download this from the Sri Lanka College of Microbiology's website. With great effort, we released this from the Sri Lanka College of Microbiology last year. This is Hospital Infection Prevention and Control Manual 2021. So each and most of the wards have been given this. If your hospital doesn't have, when you go, ask for it from the College of Microbiologists. So it has all the components which I am going to discuss and much more which I am not going to tell because of the time limit. So we need to know what are healthcare associated infections. So we need to prevent healthcare associated infections. For that, we need to know what are healthcare associated infections. They are acquired by patients during their stay in the hospital and by healthcare workers while working in hospital. So you and I will get healthcare associated infection if we do not practice the proper infection prevention and control measures. So what are healthcare associated infections? The infections occurring in a patient during the process of care in a hospital or other healthcare facility. which are not present or incubating at the time of admission. When the patient comes for admission, patient doesn't have that infection, or not, and also not incubating at the time of admission. So you know there is incubation period for each and every infection. So the patient is not incubating, know that the patient is having the infection. So can also appear after discharge sometimes. So it depends on the definition of that particular infection. UTI, surgical site infection. So it may be 1 month after. For some, it may be 1 year later. So very sternotomy for cardiac surgery. So it takes, we take healthcare associated infection for 1 year. So it depends on the definition. So it includes occupational infections among staff also. So while working, we can get. So this includes occupational infections as well. So diagnosis, as I said earlier, the diagnosis of particular healthcare associated infection should be done according to CDC, National Health Network diagnostic criteria. National Health Safety Network diagnostic criteria. So healthcare associated infections develop on or after 3rd calendar day of admission. Before that, we do not take at the time of admission or incubating. We do not take them as healthcare associated infection. So we have to suspect healthcare associated infection if the patient develops it on or after 3rd calendar day of admission to the facility. However, the infection present on admission may be healthcare associated infection if the patient had been hospitalized previously within past 3 months, 90 days. So all elements need to be present to consider as healthcare associated infection according to NHSN definition. So healthcare, why are we talking about healthcare associated infections? Increased patient suffering, permanent disability, death, prolonged hospital stay, increased need for higher level of care, may need ICU care, and increase the cost to the patient and hospitals and country. So bulk of the healthcare associated infections are surgical site infections, catheter associated urinary tract infection 40, catheter related bloodstream infections CRBSI, central line associated bloodstream infection, CLABSI, or ventilator associated ventilator associated, not bloodstream infection, ventilator associated pneumonia, that is VAP. So the risk factors for this, we do not. So there are quite a number of risk factors. Prolonged hospital stay, it is not appearing here. Prolonged and inappropriate use of invasive devices and antibiotics, and other medical condition, comorbidities, use of devices, not adhering to infection control practices, and not adhering to some isolation practices are some of the risk factors we thought of for healthcare associated infection. High risk and sophisticated procedures, immunosuppression, and other underlying patient conditions, and insufficient application of standard and isolation precautions, and inadequate environmental hygiene conditions and waste disposal. So may be transmitted from healthcare worker to patients, patient to healthcare, patient to patient, or patient to healthcare worker in all ways. So it can be through contact, can be through droplet infection, it can be through airborne infection. So other instances also can happen like foodborne, those things, but they are related to most of the time one of these. So contact, droplet, and then airborne infection. So contact is generally happens through our hands. Indirectly through an equipment it can happen. So this is contact. Mostly commonly by healthcare workers' hands. So our hands are full of bugs unless we wash them properly or use appropriately the hand rub. So droplet and airborne infection for respiratory infections. You are well aware with the COVID pandemic. So most of the time flu and even COVID is by droplet transmission, and tuberculosis by airborne transmission. So airborne transmission happen like this. And you see how long it spreads. So it is very important for us to know about how transmission occurs. And indirect spread by droplets, droplets with the infectious agent land on table, doorknobs, etc. And when we touch indirectly, someone touches contaminated objects, it comes to our hands. So then we work with our hands, and through all these, through mostly by our hands, it can be transmitted. Other indirect routes of transmission are there. Out of them, I have included them. I am not going to read everything, but doctors' white coats. Nowadays, people walk with these scrub suits. I have seen them inside buses. I have seen them in food cities. I have seen them walking around the hospitals and everywhere walking along the roads. It is not a good thing to happen. These scrub suits are there when you are working in a unit, and you wear once you enter the unit and you remove it and go home in your own clothes. But this is a pathetic situation. All walk with all scrub suits everywhere. And recommended, the long sleeve shirts are not recommended. Coats and ties actually are not recommended even in Western countries because they can get easily contaminated. And same stethoscopes without cleaning, also another problem. Another big thing is bed rail. It is in the patient's environment. So bed rail, once you touch, so you have to stand straight without touching all these unnecessarily. Once you need, you have to, but you wash hands or use the rub. So how to cough is also important because our hands are precious. So we need to cough like this, cough to the elbow, because our hands we use for do procedures. So coughing to the elbow is the main. So chain of infections also you should know. Once there is an infectious agent, there should be a susceptible host. There should be a portal of entry. There should be a means of transmission, as I mentioned earlier. So from there, it has to portal of exit, and there can be a reservoir and to come into the infectious agent and enter the host, susceptible host. So this is a vicious cycle. Our aim in infection prevention is break the chain of infection somewhere, mainly the portal of entry. That is how we focus infection, breaking the chain of infection. That is our aim in prevention of infection. So the backbone of infection prevention and control is standard precautions. We call it in Sinhala, Sammata Arakshana Kram. So generally the definition is set of very simple, not complicated, standardized. I am not telling off my head, but we have come to a consensus worldwide. They are standardized practical guidelines followed to help reduce the transmission of healthcare-associated infection in hospitals from all types of pathogens, not microorganisms, pathogens, disease-causing microorganisms from recognized and unrecognized sources. Sometimes we find it very difficult to recognize the source. So standard precautions should be followed by all healthcare workers. No exemption for doctors. I repeat, I reiterate, it is teamwork. So standard precautions should be followed by all healthcare workers in all patients. When the patient is having infection, no. For all patients. When the patient is having hepatitis B, no. When the patient is having HIV, no. For all, in all patients, at all times when attending to patients, regardless of their diagnosis or presumed infectious status. We know that patient is hepatitis B positive because we test. So there may be people incubating, so you don't know. So these standard precautions apply to all patients, not known infectious status. So that I re-emphasize. So generally, the infection prevention and control is important because the incidence of healthcare associated infections can be reduced considerably by good IPC practices, infection prevention and control practices. So that is, the IPC is a series of procedures and guidelines to prevent and control healthcare associated infections and should be applied in all settings where healthcare is provided. So you all are going to start work already done during your appointments, but now officially going to start as interns. So it is important to keep this in mind. So these things are included in standard precautions. Hand washing and sepsis, using hand rub, properly using personal protective equipment, safe injection practices, and proper use of sharps, proper disposal of them, safe handling of potentially contaminated equipment, using proper disinfection and sterilization, proper cleaning of environment and equipment, appropriate handling of waste, respiratory hygiene, appropriate personal health practices. So to what body fluids do standard precautions? Other than sweat, everything we regard as infectious, potentially infectious. So all blood and body fluids as indicated, or secretions, excretion, those things enter non-intact skin. So non-intact skin can be infectious in all mucous membranes. So you have to keep how these activities are organized in hospital. Also, as interns, you should know how IPC things are organized in a hospital. So there is Infection Control Committee, ICC, which takes policy decisions. So this is a forum for multidisciplinary inputs. So representing different units, people attend, responsible people, input and cooperation. It is not a place where we discuss rubbish. It is not a place where we discuss blame each other. No, we take policy decisions on infection control matters for further improvement. So this includes wide representation from different relevant departments. So therefore, day-to-day activities we have. So there are quite a number of consultants, nursing officers, other representing departments, consultants, and different. We can have invitees also whenever needed. But day-to-day activities, they are the microbiologists also can co-chair with the institutional head, or they can decide whom to chair depending on the circumstances. So infection control team deals with day-to-day activities. So consultant microbiologist is the technical head of the infection control, not administrative head. I emphasize technical head of the infection control unit. It includes medical officers, infection control, and infection control nurses. So they deal with day-to-day activities of infection prevention. They are members of the infection control bigger body as well, but day-to-day activities, they observe, decide, problems are taken to the infection control committee, but solutions are given day-to-day basis as well. So they are members of the infection control committee too. All technical aspects of the infection prevention and control must be communicated to the consultant microbiologist of the hospital. I emphasize the technical aspect. So these are standard precautions in the graphic manner I told you earlier. So another graphical representation. So our hands are like this because you all are going to start your appointments. You have to, I have to emphasize this. Your hands are like this. unless washed. So the physician, Hungarian physician we regard as father of hand hygiene. He pointed out the importance of hand hygiene with soap and water because it helped in reducing maternal mortality. So I am not going to tell all, but sometimes people say these are the reasons not doing hand hygiene. Takes too long? No, it is very short. Skin irritation, seems poorly located, very busy. I only touch little bit, I forgot. One time you can forget, but later you can't. I thought I did. I will do it next time. One time we can exclude. I didn't know you were watching. I should not watch for you to wash hands. It is the safety of all we are doing. Nails should be short. Should not bite when you are a medical person. You should not. Keep nails short, no polish. When you attend I am telling while working, you can do all these when attending to something else. But while working, you should limit jewelry. Should not wear jewelry, wristwatches while working. So you should not wear these because hand should be free. So jewelry should not should inhibit your ability to correctly perform hand hygiene. So remove all. Very important. So we need to have these good quality rubs, soap, running water, soap box needs cleaning regularly. So when you are a house officer, you can tell the people very friendly manner. Shall we clean this every day, 2 times a day? Likewise, you can do all these. Be a hand hygiene role model and champion. Role model, you teach others also. Champion, you do yourself only. So better to, I like you all to be a role model rather than a champion only. So the first thing is that. The other thing is some people wear gloves and use hand rub on it. There's no method for doing it so far. So gloves should be used as an adjunct to, not a substitute for hand hygiene. Some people wear a pair of gloves, touch everywhere, that encourage spreading of infection rather than control. So you have to glove use whenever necessary only. Unnecessary glove wearing should not be done. Hand hygiene is to be used before and after glove wearing as well. Gloves need to be changed and alcohol-based hand rub after each patient procedure and when going from dirty to clean sites, even on the same patient. So disposal of gloves are to be used once only and not disinfected or washed. There's no method for you to use hand rub on your gloves. So when to perform hand hygiene? Cleaning our hands at right time. 5 moments for hand hygiene. This is the 5 moments for hand hygiene. So these are the 5 moments I'm rushing through because it is important to get the basics for you. Before touching a patient, first one, before clean or aseptic procedure, important. Third one, after body fluid exposure risk. Fourth one, after touching a patient. And fifth one, after touching patient surrounding. So third moment, after body fluid exposure risk, you have to wash your hand with soap and running water. No hand rubs. Second, before clean and aseptic procedure. For aseptic procedures, of course, we encourage you all to wash your hand with soap and water, running water. And other instances, you can use the rub. So at the point of care, where is the point of care? Where the patients are located. Big one, the whole body's healthcare zone. Individual patient zones are patient zones. Whenever you enter a healthcare zone, you wash your hands with soap and water, and then you keep your every belongings first in the secure place. Then you wash your hands in the hand washing area, and then go to each patient zone. In each patient zone, you have to adhere to 5 moments for hand hygiene. The other thing is use of, what is this? What is this? Your mobile phone. 25,000 germs per square inch. Please do not take your stamps, your mobile phones to patient zones. Keep in a secure place in the healthcare zone. Please don't take. Not telling with my off head. It says the mobile phone is dirtier than you think. Toilet seats are clean. So this is the actual thing. You take everything to your home to make your people at home sicker. So it is important for you to clean your mobile phones with alcohol. You have to have a protection. I think all people have the protection with some sheet on it. And you have to clean with alcohol before you leave the place. So what to perform? The correct technique of hand hygiene. There's no way of demonstrating it. It is important to perform proper technique. That is why I told you, I want you to go through, download your this manual from the College of Microbiology's website. Whenever you come to, if you are come to our hospital, definitely we will have a session for that, and each other hospitals also do the same. So why this technique is important? The red areas are very contaminated. So the orange one also, most of the areas are mixed if you just watch. So that is why this technique is important. So it will be shown to you by the infection control nurses and the microbiologists when you come to the hospital. So the personal protective equipment, some of these things you all have already used when you are working in wards. So I am not going to tell all these, you all are aware about. The respirators also important. PPE, not always you wear all PPEs. It depends on the procedure you plan to perform. So when you are going in the ward round, always wear everything, it becomes a joke. So what PPE you are going to wear depends on the procedure you plan to perform. So type of transmission-based precaution. For respiratory thing, you have to wear mask or respirators. Respirators when needed. When you do some airborne transmission occurs or very droplet transmission occurs, we do the mask. And respirators, when to use the respirator is also very important for you to know. Unnecessary respirator use also not indicated. So PPE before entering the patient room, remove PPE at the patient's doorway when you go out or outside the room. But respirators, removal outside patient's room after closing the door. That is important. Respirators have to be removed after closing the outside the patient room after the closing the door. So donning, these are WHO website. So I am not going to tell all these within 1 hour. So donning your PPE, there is a sequence. You do hand hygiene, then the sequence donning, you wear. And then doffing sequence. So I encourage you to read all these before starting your appointment. So doffing sequence. So this is the doffing sequence. So it is important. There can be small changes in some circumstances, but if you think that there is any contamination in between, removing PPE at any time, you have to perform hand hygiene and then continue removal after that. Then I get on to sharps. So this is a big issue when new HOs come and new nurses come. So because you don't know how to handle sharps. So work practices should be adopted to minimize the risk of getting infected. So bloodborne infections, hepatitis B, C, HIV. So HIV, all people are afraid of HIV, but the minimum risk is there with HIV. But hepatitis B risk is higher. The second one is C. So avoid using sharp whenever possible. So don't use sharps if not necessary. So essential things you have to use. So don't tell that microbiologist NHS said not to use sharps. So when it is needed, you have to use, but avoid using sharps whenever possible. Sharps such as scalpels, lancets, needles, syringes should be single use only. There's no way of using them again. There's no way, no recommended method. Take care to prevent injuries when using handling after procedure. Cleaning and disposal of sharps, but some syringes, needles, those things are not clean. Okay, scalpels not clean, lancets not clean. So it should not be done. Avoid recapping those needles, but sometimes recapping is needed for hematological testing, collection of blood. So in such situation, scoop method, one hand method should be used. You keep the cap on the table and then put the needle syringe together into that and then discard. Okay. User has to discard sharps directly into the sharp bin. I emphasize. There's nobody there for you to discard sharps. We do sharp. The producer has to discard directly it into the sharp bin. So always ask for a sharp bin close to you from the staff whenever you use sharps. So sharp bin should be there, should not be kept on a kidney tray or on the table, where on the BHT or on the patient's bed. It has to directly go to the sharp bin. So these are the commercially available sharp bins we use in some of the wards here. So do not remove used needles from disposable syringes by hand. So we discard both together into the sharp bin. So we do not remove needles from the syringes. Do not bend, break, or otherwise manipulate used needles by hand. So by using all these, you can minimize. Discard sharp directly into the sharp bin, I already said, at the point of care. Dispose of sharp bin whenever 3/4 full. Seal it. Ask the board staff to seal it and remove. It should have a handle. Always should have a handle for the sharp bin. Sharp must not be passed directly from hand to hand. It should directly sharp in. There are safety needles and syringes also. Whenever you finish the task, it is closed. The needle is in. So they are expensive, but we have requested the ministry to buy them. But I don't think that it will come soon. Then prevention of healthcare associated infection. There are clinical guidelines in this book, so I cannot tell everything. So always practice clinical guidelines whenever devices are being used. Okay, it is important. By that way, we can prevent infection. So the other thing is, by practicing proper cleaning, disinfection, and sterilization, it is important to minimize healthcare associated infection. So what is cleaning? Cleaning is the first step. No point in disinfecting nor sterilizing without any cleaning. So must be carried out before. So as the leader of a team, you should know what is happening in your ward. So when after house officer, as the house officer, also you are a medical person. So you need to know whether it's been done. Must be carried out. Cleaning, the first step. So disinfection or sterilization is the second one. So disinfection is done for inanimate things. Living people, we use antiseptics. For alcohol, povidone we use on our hands. So they are antiseptics. Disinfection we use to keep the process of elimination of nearly all. So it is not sterilization. Nearly all recognized pathogenic organism, but not necessarily all microorganism from non-living that is equipment and environment disinfection. So we have to use correct disinfectant, correct concentration, correct contact time, and correct procedure. So sterilization process by which complete elimination of all microbial forms. So there's no relative thing, all finished, including spores, an absolute process, complete process. So choice of whether it is cleaning for all, but disinfection or sterilization depends on the risk involved. So it can be low-level infection, disinfection, high-level disinfection, or sterilization. It depends. If it enters the sterile site, definitely sterilization is needed. So some high-level infection, if it enters a mucous membrane, we need high-level disinfections. Likewise, so there are guidelines available, charts available in this book. Please refer to them. So the equipment, it is important. I think you all are aware about this biofilm. Biofilms, equipment, the organisms actually get sticking qualities there with the biofilm. That is why cleaning with brushes, the removal of biofilm, cleaning as the first step is very important. So, and then about disinfectants, you need to read the pack insert. So the doctors have a habit, they just do what the nurses give with the solution. You need to read the pack insert properly before use. Follow manufacturer's instruction in preparing. It is very important. So you are there, you are medically qualified, you need to know what you are using. Then I told you, the international is HIV, hepatitis B and A. So it's hepatitis C. Most of the people are afraid of HIV, but the risk is with a needle stick injury. Needle stick injury or mucous membrane exposures happen when the new recruits come. So you have to be aware about this. That is why I am telling it is important to take care if such an accident happens, what to do. So if such a thing happens, you minimizing, avoiding is the best, but accidentally happens, needle stick injury or mucus exposure to blood and body. You have to immediate care to the exposure site. Allow the wound to bleed spontaneously. You should not squeeze. Wound should not be sucked. Should not be sucked or squeezed just to encourage bleeding. Bleeding. It can lead to dissemination. So wash wound and skin with soap and running water. If mucous membrane, flush with water. Irrigate eyes with clean water. Report the incident. It is important. You have to report the incident. Report the incident. There is a national circular for this. You have to report the incident. There should be a report incident book in the for this purpose. Especially, there is another report incident book. There is a second report incident reporting book for needle stick injuries. Report. There is a patient side and your side, and quickly record. You can inform the infection control unit and come to the infection control and do the needful with the incident reporting register. You have to come with the incident reporting register. In the case of our hospital, I am not, different hospital has different methods used. Our hospital, after hours, they have to go to the OPD doctor, and then it's necessary to go to the injection room. Then vaccination of healthcare workers, it's important. I think you all must have taken all 3 vaccines, 3 doses, 0, 1, 6 months. I hope you all have already taken. And ideally, your antibodies should be tested, but I don't think that you all have tested. Ideally, it is better if you can get it tested, because no kits at the moment in the government hospitals. But I'm not telling you all to get it done, but it is better for you all to know your antibody level. If you have been vaccinated with 3 doses, and protective titer is equal to more than 10 MIU per ml, with few exceptions. 10 is enough. But if you are working in a dialysis unit and some other immunocompromised patient, so sometimes we ask for, some of the countries ask for 100, but 10 is enough for our purpose. And you have to keep the results in a safe place to have the look when necessary arises. Till the next birth, you have to keep it. So otherwise, we don't know whether it is adequate or not. Then I come to the waste management. The other thing I see as a microbiologist in a hospital, the doctors think others are there for you to remove the waste. No, it is, we are working in a team. So segregation is at the point of care. So when the waste bins, different categories, different segregation color code is there, you have to segregate them and put. So for instance, yellow is for infectious waste. So you have to do it, discard it then and there. So you should not keep anything anywhere without discarding directly to the waste bin correctly. So sorting out of waste at the disposal site or before transportation is not recommended. So this is generally the color code. First one is the sharp bin. Yellow is infectious waste. Cleaned paper is blue. And Samanya Kasal is general waste. And plastic is this orange. Viduru is this glass. And some hospitals have green for food. So some hospitals may not be having a whole color code, but at least should have a sharp bin, should have in the infectious waste one, and then the at least Samanya Kasala general waste. And some hospitals have all. There are problems at the moment with bags, bins and everything, but infectious waste you have to take care. General waste you have to take care. Sharps you have to take care. So this is in our book. Other than this, now we have extended these for in cancer hospital, like you all are not going as interns. The purple color is cytotoxic waste, brown is metal waste, and gray is electrical and electronic waste, and white is pharmaceutical waste according to our book. So it is important for you to go through that also. If the spill is happen, blood spill on the floor in your ward. So cleaning service person and come and ward to clean. That is not the correct way. So that spill contains infectious pathogens. So heavy duty gloves should be worn by not you, the staff attending to that. Generally, our staff should attend. There is a circular, but different practices happening in the wards. Sometimes cleaning staff does, but I tried my best to correct it, but it's not happening. It has to come from the upper, for the ministry level. There is a circular, so it has to be implemented by the Ministry of Health. So where the people have to wear, not you, you should know what's happening. That is why I am telling this. Wear heavy duty gloves, so the spill with absorbent material. But nowadays we don't have wadding problems. So some absorbent material, cover with freshly prepared sodium hypochlorite. So nursing staff and other staff and infection control license do that. Leave for at least 10 to 20 minutes and then cleaning is done and removing it with gloved hand, heavy duty gloves, and do the need. So this is spillage of spill kits have to be there. Generally, Clorox is, this is trade name, but hypochlorite, freshly prepared 1%. So generally 24 hours prepared one has to be there in a closed container. So most of the hospitals, we prepare the spill kits. Whenever emergency happens, you need the spill kits. So you need to look at what does spill kit contain. All the items needed have to be there in the spill kit. So there should be a measuring cup and hypochlorite in a container have to be there, so they can prepare if prepared one is not there. So this is the freshly prepared. I am not going to read this, what I said already, freshly prepared one. So safety issues, I already mentioned needle stick injury, reporting accidents. Very important. Lot of patients, unknown patients, maybe they are around us with bloodborne infection. So needle stick injuries, avoid it first by practicing proper infection control measures. And if accidentally happens, you have to report it with the report register and first aid initially, followed by reporting it quickly. Best results within 2 hours, but at least within 24 hours, you have to do that. And immunization, I said, hepatitis B. The other thing is chicken. I think most of y'all must have got chicken pox already. If not, it is better for y'all to get the chicken pox vaccination 2 doses. Needle stick injury, actually, I already informed you about this. Clinical guidelines adherence. I said I am not going to read the next slides for y'all all, but there is something called bundle approach because y'all are doctors, higher level. So you need to know, nurses also know this bundle approach. That is why I included these bundles. We do CVC bundle, central venous catheter bundle, UTI bundle, web bundle. Likewise, there are different bundles we talk about. So it is in that book also. So if somebody tells bundle approach, if you don't know, it is not good. So adherent to clinical guidelines, applying standard infection control principles to all situations at all times is important. So what is bundle approach? It is different stages. If you do one thing, it may not be adequate. Series of things, if you do 3 to 4 items, 3 to 5 items, it will be more effective to prevent infection. So bundle approach is that. Some of them actually. What are care bundles? A care bundle is a collection of interventions, usually 3 to 5 that are evidence-based. I am not telling you on off my head. So they are evidence-based things. All clinical staff know that these interventions are best practice, but frequently their application in routine care is inconsistent. So in a 3 to 5 things, if you do, the outcome would be the best. So it is important for you to. The care bundle is a means to ensure that the application of all the intervention is consistent for all patients at all times, thereby improving outcome. So you try to do these bundles relating to central venous catheter, I said. I am not going to read, just for you to have enthusiasm to read. So this is bundle for series. So there are bundles, ventilator associated pneumonia. So hand hygiene an important thing there when infection control is concerned. In urinary catheter care bundle, insertion, insert only lot of things. Competent healthcare worker to aseptic techniques, I am not going to. So likewise, there are quite a bundles you take and try to adhere to them. With time you learn, don't get afraid. You can't do everything at a time. So with time you learn, but enthusiasm has to. The other thing is notifiable diseases. So I think somebody must have taught about this. Timely notification of infectious diseases are must. So you must have been given notifiable diseases list. It is there in our book as well, I think. Special word about tuberculosis because increasing numbers of pulmonary and as well as extra pulmonary TB are there. Hope areas in boards should be implemented. Some they have. N95 mask when respiratory procedures are done with tuberculosis patients suspected. So it is important for you all to notify TB patients. So it is duty of the medical officers to notify all this. So what happens is people have to go behind. It is that I know the intern is actually we have done the internship now, so we know how difficult it is. Everything is told to you. It is difficult. By doing all this, you learn, ultimately you realize how important for you to work in the internship period. That is the best place to learn things. So it is your duty, keep in mind, you can forget things, but try to do the best by notifying all the notifiable diseases. I do especially emphasize TB because it is on the rise. So thank you for your patient listening. So if there are any problems, I am ready to answer. Hello, can you hear me?
Yes, madam.
Hello.
Yes.
Yes.
Yeah. Right. That was. Thank you very much, madam. That's Geetika Pattabandige, consultant microbiologist and the president of College of Microbiologists, for delivering that very valuable lecture. I think that's a very important lecture for their career as an intern and starting.
Definitely.
Yes, madam.
Because I
was
included most of the practical things here.
Yeah, because we have not included this infectious control training program in previous years. So this is the first time we are introducing this program.
Roshan, from
Yes,
the
madam.
college
So,
also we requested this. It is very important because we come across a lot of issues because they don't know.
Yes, yes, true. So also we will share these recorded lectures for them to refer later also.
Okay.
Also, thank you very much, madam, for taking the time and organizing this program for tailor-made for these interns. Yes. So thank you once again. So there's a question. Yeah, madam,
if there are questions, they can ask.
Yeah, madam, do we need COVID vaccine 4th dose before internship?
I think all the healthcare workers are requested to take. Neither.
Oh, madam.
Taken. Have they taken?
I think they were available at the emerge level, so those who are not taken can reach the emerge and get it organized, I think.
Yeah, some of the hospitals also give on request.
Yes, National Hospital, like yes.
Yes, we also give on request. Yes. I wish them all the very best for their internship.
Right. Thank you once again, madam. Yes. So thank you, madam. So tomorrow we have psychiatry training session. Please join by 7:30 tomorrow. So we'll start at 7:30 and we will finish early. And also there will be there's some modification for today's registration link. So we will share another link tomorrow. So Friday we will have the closing session addressed by the DGHS. So tomorrow please join by 7:30. Right. Thank you.